Well, hello and welcome to our 14th annual Resident Scholarly Works Virtual Summit hosted by the Illinois Academy of Family Physicians. I'm Ginny Flynn and I'll be the moderator for today's webinar. This is our 14th annual summit and we have 14 resident presentations on tap for today. So unless you're presenting, please make sure to mute yourself. Before we begin, we have to do our required CME. First, I want to make sure we show our diversity, equity, and inclusion statement, and that we hope today's activity lives up to our goals and expectations. The Illinois Academy of Family Physicians is accredited by the Accreditation Council for Continuing Medical Education, or the ACCME, to provide continuing medical education for physicians. The IFP designates this live activity for a maximum of 3.5 AMA PRA Category 1 credits. We adhere to the conflict of interest policy of the ACCME and the AMA, and it's the policy of the IFP that all individuals in a position to control the CME content disclose any relationships with ineligible companies upon invitation to participate. All individuals in a position to control content for this activity have indicated they have no conflict or relevant financial relationships to disclose. Our presenters for this block, Dr. Schaefer, Dr. Lux Karanayagam, Dr. Morobi, Dr. Rojas, Dr. Zatina Huska, and Dr. Gonzalez Alvarez report no relevant financial relationship to disclose. For those of you who are submitting CME credit, you will have a link in the chat and will be sent to you by email. You'll need to submit a credit claim for each presentation that you view today and only for the presentations that you view. This webinar is being recorded and will be posted on the IFP YouTube channel and shared with the presenters. Just a couple of quick announcements before we begin. We have two upcoming foundation fundraisers at the White Sox game this Sunday and with the Chicago Sky basketball team later in September. And if you want to go bananas at Wrigley Field, we have a silent auction for 3 tickets to attend the Savannah Bananas game on Friday the 24th at Wrigley. Don't forget about the Family Medicine Midwest Conference. Registration is now open until August 30th, and that is in Indianapolis. And we are hosting next month a free CME event on the upcoming Illinois law that takes effect with end-of-life options for terminally ill patients act. That law takes effect in September, and we'll be hosting a CME webinar on June 18th. And don't forget, this summer is the time to submit nominations for our annual IFP awards. Those are due on August 1st, and you can find that right off our homepage. So how will this work? Our presenters should have their presentation ready to go on their desktop. Each resident will have 15 minutes to present their slides, and we'll get a 2-minute warning in the chat and verbally. Everyone else shall stay muted. And then at the conclusion of the presentation, our assigned reviewers are the only ones who should ask questions. They can either unmute and ask verbally, or feel free to put it in the chat box and I'll read it aloud for the resident to answer. With that being said, let's go ahead and get started with our first presenter. At this time, I'm going to stop sharing my screen. And welcome to our first presenter, Dr. Kyle Schaefer, who's with the UChicago Advent Health Hinsdale Family Medicine Residency Program, presenting his completed research. And for this presentation, I'm going to ask Dr. Addison Montgomery and Dr. Ava Becker to be our reviewers. You may know that's not their real names. We have nothing but TV show docs who will be providing reviews and asking questions. Dr. Schaefer, I can see your slides. Everything looks good and we can hear you. So welcome and good luck. And the clock will begin when you do.
Okay, thank you for that introduction. So my name is Kyle Schaefer. My project is meningococcal vaccine rates and refusals during well child visits at Hinsdale Family Medicine Center. My advisors are Dr. Elizabeth Bockold and Dr. Michael Kean. I have no potential conflicts of interest or disclosures. Here's the agenda. Starting with background. So the U.S. has 3 types of meningococcal vaccines, and each helps protect against different serogroups of meningococcal disease. So the MenACWY vaccine protects against the 4 serogroups A, C, W, and Y, commonly known as MenVeo or MenQuadV. The MenB vaccines protects against only one serogroup, serogroup B, commonly known as Bexsero. And then there's a combination vaccine, MenABCYW, that protects against all 5 serogroups. But this one's much less commonly seen, and we'll get to that. So the CDC recommendations for meningococcal vaccines are for the quadrivalent or MenACWY vaccine. It's a blanket recommendation to all 11 to 12-year-old adolescents and a booster at age 16. In certain situations, individuals aged 2 months or older should also receive the vaccine series as well. And for Men-B, it's recommended a shared decision-making model with preferred ages 16 to 18, and it's a 2-dose series given 6 months apart. And individuals at increased risk in certain situations are recommended to start at age 10. So as you can see, they're recommended at different ages, and so that's why that combination vaccine is typically not given or seen as frequently. So this is for educational purposes, but these are the indications for why each vaccine would be given for somebody at an earlier age if they're at an increased risk. So for instance, certain medical conditions like complement component deficiency, functional or anatomic asplenia, including sickle cell disease, which would be the most commonly seen, or HIV, medications such as complement inhibitors, or settings or occupations such as traveling to areas where it's common, microbiologists who work with bacteria, military recruits, first-year college students, or being a part of a community experiencing an outbreak. So some of these do overlap with the Men-B, but there's less indications for the Men-B. So this project's objectives included educating residents and attendings about meningococcal vaccines at the Hinsdale Family Medicine Resident Clinic, assessing resident and attending comfort for meningococcal vaccine indications, timing, and counseling via survey, assess reasons for vaccine refusal, compare vaccine rates of the Hinsdale Family Medicine Residency Clinic in DuPage County, and observe if a difference in vaccine rates is observed after implementing education about CDC recommendations of the meningococcal vaccines. So for intervention and data collection, so an educational presentation was given in spring 2025, and an email was sent to residents and faculty at the Hinsdale Family Medicine Center regarding the CDC meningococcal vaccine recommendations. There was a pre and post presentation survey completed. And to assess the vaccine rates and refusals, well-child CPT codes from 2024 and 2025 were obtained to identify visits where vaccines are routinely recommended and administered. So the well-child CPT codes were 99383 and 384, which are new preventative visits with ages 5 to 11 and 12 to 17, and 99393, 99394 for established preventative visits in those age ranges. And then a manual chart review was done to review immunization status. So the survey for both pre and presentation was the same. It contained 6 statements and 5 answer choices. The first 3 statements were assessing Men-ACWY, vaccine indications, timing, and counseling. So it's I feel blank, knowing the indications, timing, and counseling. And the last 3 statements are similar to the first 3, except they're assessing Men-B, indications, timing, and counseling. And the answer choices were ranging between highly confident, comfortable, neutral, not confident, comfortable, and strongly not confident, comfortable. And the educational presentation survey responses are shown here. In blue, the pre-presentation responses. In red are the post-presentation responses. So in general, people felt more comfortable when they got education about vaccine indications, timing, and counseling. So this chart is showing the total charts by well-child CPT codes obtained in the year 2024 and 2025. And with the caveat that the 2025 data is up to August 31st. So there were 662 charts obtained in 2024. And then in the patients age 11 or older, there were 417 charts of those 662 that met that criteria. Patient vaccine status up to date, meaning 1 vaccine between age 11 to 12 and 2 vaccines by age 16 was 394. And then our clinic's meningococcal quadrivalent up-to-date vaccine rate for 2024 was 94.48% and 89.26% in 2025. The lower section is the meningococcal B vaccine rate. So our patients age 16 and older were 130 in 2024, 61 in 2025. And then when we see which of these patients have received at least Bexsero once, we get a rate of 18.46% and 16.39%. So quite a difference between those rates, and I'll get into that. This chart is from the Illinois Department of Public Health, showing protection percent trends of the meningococcal, the quadrivalent rate in DuPage County by school year. So on the far left, we have the 2015 to 2016 school year showing a protection rate of 95%. And then you can see a trend typically of a slow decrease over time all the way up to 92% in 2024 and 2025, with one outlier year here. This chart shows the reason for refusal or unvaccinated status of meningococcal quadrivalent vaccine at HFMC by year. So we have 2024, 2025. Religion is the most common reason for refusal. So in 2024, 5 were not specified. There was 1 Serbian Orthodox and 1 Hebrew Israelite. And for 2025, there were 7 not specified and 1 Christian. The next most common reason is vaccine was not available at appointment and family did not follow up for the patient to receive. And that is getting at our clinic's vaccine fridge was actually out of commission for a few months. So they would have to schedule a return visit to actually get their vaccine. So a bit of a barrier there. The next most common reason was the immunization was due, but it was not documented in the note why the patient didn't get it. The next most common reason was declined, reason not specified. Parent requested to review or obtain old vaccine records prior to child receiving vaccines, although they didn't follow up. Parent requested for the patient to receive it at a future appointment, although the family did not follow up. The vaccines were documented as up to date, although they were not up to date. Family member had a seizure thought related to vaccines, and a parent felt vaccines were unnecessary and poison to the body. So for the discussion, the Illinois Department of Public Health School Vaccination Coverage Dashboard reported DuPage County had a protection rate of 92% for the 2024-2025 school year compared to our clinic's quadrivalent rate of 94.5% in 2024 and 89.3% in 2025. Our clinic's Men-B vaccine rate, and those are for patients who received at least 1 vaccine for 2024, is 18.5%, and 2025 is 16.4%. And the IDPH did not have coverage about the Men-B vaccine to compare to, because most likely it's due to that shared decision-making model. So it's not a blanket recommendation. The most common reason for vaccine refusals is religion, followed by vaccine unavailability, and immunization was due, but it was not documented in the note. So the decline in 2025 rates can be partially attributed to our clinic temporarily losing availability to give same-day vaccines at appointments because our vaccine fridge was out of commission. And this required patients to schedule a return visit for patients to receive the vaccines, which is an addressable barrier. And the lower vaccine rate reflects a decline in vaccination coverage seen throughout the U.S. So identifying barriers to vaccination and giving education on talking with parents about vaccines to providers will likely be beneficial to increasing vaccine rates and preventing disease outbreaks. So if vaccine records are lost, it's a good consideration to actually give vaccines as appropriate or check antibody titers because patients may not follow up if they are tasked, or should I say parents wouldn't necessarily follow up if they're tasked with finding old vaccine records and then bringing them in. CDC catch-up immunization schedule for children and adolescents is a great resource for getting children caught up. The difference between the quadrivalent Men-ACW vaccine rate versus the Men-B rate, again, that's a big difference between the blanket recommendation of the quadrivalent vaccine versus the shared decision-making with the Men-B rate. And there's only a handful of colleges that require the Men-B or Bexsero vaccine. Those are typically places that have had outbreaks previously, whereas everybody is typically required to get that quadrivalent meningitis vaccine for most colleges. It's also a good reminder that it's important that reasons that they're not given are documented for giving resources for us to be able to identify trends of why are people declining. And it's also just good practice to do that. Project limitations included not all of our pediatric patients may be accounted for if not seen or coded for in a well-child visit during the project's data collection timeframe. Teens may be less likely to be seen yearly for well-child visits than younger kids. The 2025 data is only up to August 31st, and the Men-B vaccine rates may be more difficult to accurately obtain since it's administered near when patients are college-bound. So if a patient moves away, it may be difficult to monitor if they receive a second dose. Here are my references. Any questions?
Thank you so much, Dr. Schaefer, for your presentation. At this time, Doctors Montgomery and Becker, either one of you can either unmute and ask your question. Dr. Becker has put one in the chat that I'll read aloud, asking if you have any plans for next steps.
Yeah, so the next steps would be completing the rest of the data and kind of seeing if there's an actual change. I gave the presentation with education in hopes that the vaccine rate would actually improve, but the vaccine rate actually went down. There could be that confounding kind of variable. Hey, we lost the availability to actually give vaccines. So it's really like figuring out, hey, does education actually help with counseling or perhaps education about addressing vaccine hesitancy? The CDC actually has a good, article about addressing vaccine hesitancy with parents, about giving a strong recommendation for vaccines. It's almost you want to be ready to counsel, kind of like having strategies that you almost assume that the parents want to get the vaccine, but I think giving a presentation focusing on that and seeing if that can help providers kind of convince or give their strong recommendation that parents should be getting these vaccines for their kids would be helpful.
And one more question for you from Dr. Montgomery. Can you talk a little bit more about what was the education you did between your pre and post confidence survey, and what do you think made the most impact in improving provider confidence?
Yeah, so that survey used a lot of tidbits from the CDC website, and most people weren't aware of like Bexsero in general because it's kind of a newer vaccine that was recommended. So I think that was just making people aware of it. Like if you're not aware of a vaccine and not recommending it, then people aren't going to be getting it, right? And I think what helped the most is giving like showing trends of like outbreaks, like hey, these people are at risk and they could benefit from this vaccine. And so giving people like either like phrases or how I would commonly tackle like a patient or parent that was kind of hesitant to want their child to have this vaccine, right? And I mean, there's risks and benefits to everything, right? So we want to give an accurate picture of what those are and let them ultimately come to that decision. But I think the benefits vastly outweigh the cons, right?
Fantastic. Stand by one just for a minute and see if we have any other questions from Dr. Montgomery or Dr. Becker. Looks like you may be good. So thank you so much for your presentation. We are a little bit, only a couple of minutes ahead of schedule, but I see our second presenter is already on board. So I will ask Dr. Lux Karanayagam, if you are willing to go a couple minutes early, you can let me, I see you. So does that sound okay to you?
Yeah, definitely. And great job with the pronunciation.
Thanks. Okay, well, I'll give you a minute to get set. I believe we have your reviewers on board. And while you're getting ready, allow me to introduce Dr. Anita Luxkaranayagam from the Prime Health St. Mary of Nazareth Family Medicine Residency Program in Chicago. For her presentation today, your reviewers will be Drs. Meredith Gray and Dr. Sarah Reese, who I believe are on board. So once you are ready and in full screen, just a reminder, you'll have 15 minutes to present your slides. You'll get a 2-minute warning in the chat if you get to that point, and then at 15 minutes, you'll be asked to complete. You can have fewer than 15 minutes, and then our two reviewers will have questions for you at the end. Do you have any questions for me in the meantime?
I don't think so. Well, can you see my screen and my slides?
Your slides are up. I can see you and your sound is great. So whenever you're ready,
Perfect.
the clock will begin when you do. Good luck.
Okay, perfect. Thank you so much for having me. Good morning, everyone. So my research project is about patients' perception of self-flourishing at a FQHC in Chicago. So I'm Anita Lux-Karanigam. I'm currently a PGY3 at Prime Health St. Mary's of Nazareth Family Medicine Program. So some of you might be kind of wondering already what is flourishing, and I'll definitely get into that more with the presentation. My goal for this project was to just get a baseline understanding of patients' perception of their own flourishing in the patient population of the clinic I work at, which is an FQHC. And like I said, I'll go a little bit more into what flourishing is if you're not familiar with that concept already. Um, based on this, the results of this project, I do have more steps of kind of the bigger goal of a bigger project, which is based on kind of already tools that exist, creating a tool that primary care providers can refer to and provide patient resources to patients to promote flourishing. And then from there, evaluating how that intervention actually helped patients with their flourishing scores based on the flourishing index. So I'll go into more detail about all of that. So my idea for this project kind of started when I was an undergrad and I was taking a medical anthropology class. And my professor had put up this definition from the WHO of the definition of health, which was a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. That made me kind of question in situations when we're in the primary care office and we have the patient fill out like the PHQ-9 and the GAD-7, but they score very low, they score 0, they score negative, they screen negative for depression or anxiety. Is there a role for primary care physicians to do more to improve that patient's well-being? My idea was kind of like just because they scored 0 on these screenings, that doesn't necessarily mean that they're completely in a great state of well-being in these different kinds of domains. But I feel like we don't have a tendency to evaluate that in the primary care setting. And I was wondering if that was really something that's even plausible in primary care, if there's a role of that in primary care, and what would that look like? Um, so I'll go first into what flourishing is. So in that same class I took in undergrad, my professor introduced this concept of flourishing to me. Um, One of the leaders in this space of like positive psychology is Dr. Tyler Vanderweel. He's a professor at the Harvard School of Public Health. And he's published a lot of work related to this. And he's identified 5 domains of human life that he says one needs to do well in order to be flourishing. There are many definitions of flourishing, but the way that I felt like kind of made sense to me and seemed concise was a term that describes a status of well-being beyond a neutral state. So kind of like what I was talking about before, someone that it's not that just that they score 0 on the PHQ-9 or GAD-7, it's kind of that their well-being is even beyond that. So he describes these 5 domains of happiness and life satisfaction, mental and physical health, meaning and purpose, character and virtue, and close social relationships of areas that he believes if they're very strong and healthy, that would lead to a state of flourishing. As you can see, there is a 6th domain on here that's italicized. So he also mentions financial material stability. The reason it's not considered part of these like 5 domains that he defines as needed for flourishing is that he tries to argue that financial and material stability is not absolutely necessary for flourishing. However, it is something that will, if that is present, that probably will lead to much greater outcomes in terms of sustainability of those other domains. I think we think of, our patients that are in really difficult financial situations or like have housing instability. And you can imagine, I'm sure you've experienced, it can be really hard to focus on these other domains or put energy towards these other domains if that area isn't really stable of financial and material stability. So I think just wanted to bring up that point that it's not like absolutely necessary to have that in order to be flourishing. However, having that really is a privilege that can allow those other domains to really be strengthened. Um, so initially I did a project in medical school where I had interviewed some primary care providers at an FQHC to see kind of what they thought about this concept of flourishing and what they thought was like the feasibility of promoting flourishing in a primary care setting. And I did get mixed reviews, but overall, it seemed like people thought it was a good concept in an ideal world where, time wasn't as much of a barrier. There was more compensation for spending time talking about these things with patients, etc. So some of the barriers I did identify was that providers felt like if you did talk about flourishing with patients, that they would need a resource to kind of refer patients to. So if patients are kind of scoring low on these flourishing scales or measurements, that they would be able to be like, hey, like this is a resource I have for you. So that's kind of where this next step in my project comes in. So there's many different in the flourishing positive psychology space, there's many different measurements of flourishing. I choose for my project to include the flourishing index that was created by Vanderweel's team. Um, to evaluate like whoever's answering these questions, what their kind of flourishing score is based on those domains I mentioned earlier. So I created a survey that basically described this flourishing index questions and included a Likert scale from 1 to 10 with how much they agreed with these statements or questions. So just to briefly go over it, the flourishing index includes 12 questions. Each two questions correlates with one of the domains I was mentioning earlier. So overall, how satisfied are you with life as a whole these days? In general, how happy or unhappy do you usually feel? In general, how would you rate your physical health? How would you rate your overall mental health? Overall, to what extent do you feel the things you do in your life are worthwhile? I understand my purpose in life. I always act to promote good in all circumstances, even in difficult and challenging situations. And I'm always able to give up some happiness now for greater happiness later. I'm content with my friendships and relationships. My relationships are as satisfying as I would want them to be. And how often do you worry about being able to meet normal monthly living expenses? And how often do you worry about safety, food, or housing? So I did provide these questions to patients in my clinic to be completed while they were either waiting to be roomed or waiting to be seen by the provider. And a associated Likert scale was provided for each of these questions. So for my results, I really am still collecting my data, so I didn't really have much to provide for today, but I still think there's a lot of opportunity to talk about this project more. So this project was really just kind of like that first step to get a baseline of what this patient population perceives their flourishing to be. So for my next steps, so right now there's not an existing resource that has been shown and been well researched to provide strong evidence-based support that using this resource improves flourishing scores in patients in a primary care setting. So the same group I was referring to earlier, led by Dr. Vanderweel. He at Harvard, they have something called the Human Flourishing Program, and they created this app that people it's like easily it's freely accessible where they allow you to kind of go through the same survey that I just mentioned before that I provided to patients, and then you get a flourishing score. And then from there, they provide exercises to try to improve that flourishing score. And they kind of have it separated into different categories. So the app itself, from what I could gather, has not actually been shown to, if when used, it does improve flourishing scores. However, the exercises that it does include itself has really strong evidence to improve well-being and have like more positive health outcomes. So in general, there's more specifics about the exercises, but they're broken down into cognitive exercises, behavioral exercises, activities related to institutional and relational commitments, and activities to address psychological distress. So some of the cognitive exercises include like imagining one's best possible self, gratitude exercises. Some of the behavioral exercises are related to volunteering, kind of identifying character strengths, and trying to utilize that more in your life. Activities related to the institutional relational commitments. There's some activities related to like romantic relationships and marriage, and improving the quality of that, as well as like attending religious services. Um, and then the activities for addressing psychological distress include like self-help books, CBT workbooks, like interacting with a counselor specifically. So the the idea would be after this phase of this research project is completed with this data collection, um, I would come up with a tool that is more applicable to the primary care setting, to provide to providers. I think right now in this project, I'm the only provider that would be doing that. Um, but to utilize that resource for patients that do score low on these flourishing on the flourishing index. And then subsequently see what their scores are like after that intervention. I think the Flourishing app is a really great beginning point to create this resource. However, I personally found it to be a little hard to digest unless you're already familiar with the space or already like comfortable with the concept of flourishing. So I think ideally it would be nice to create a resource that primary care providers, if they just have like a basic, or at least could introduce like a basic understanding of flourishing, and then just kind of discuss more into detail of, hey, my patient scored low in this domain. These are exercises that we would recommend to provide to patients to help bring up their flourishing score.
You have about a
Um,
minute remaining.
Okay. So that's kind of the next steps of the project. And then like I said, after that intervention is introduced, then I would assess the same flourishing index to see if scores have gone up after that intervention. So these are my references and just any questions.
Thank you so much, Dr. Lux Karanayagam. Dr. Sarah Reese or Dr. Meredith Gray, the floor is yours for questions. And it looks like Dr. Reese has asked, this is a great and unique topic, love it. What is one practical thing that you will take from learning more about flourishing that you will add into your attending practice?
I think I initially came up with this project when I was in medical school, and I think as a medical student, I had a more ideal version of what I thought primary care visits would look like. And I did agree with when I did my initial project when I was interviewing with primary care docs about how much time is a barrier. So I think it really just when I get to know my patients, if they bring up like, hey, I'm struggling in my relationship or I'm struggling with my self-esteem or finding meaning at work, just using any of these resources that are, like I said, easily accessible on the app, and even just like briefly reviewing it with patients. I think I always like to give like a physical resource to my patients so that they can review in their own time. But I don't, like I said, I don't think what exists out there is really as digestible for patients. So I think even just kind of going through some of these exercises, and talking it over with them in like a few minutes, I could see myself doing that. And hopefully that could have some positive effects.
I'm just gonna say mine out loud. Has there been a lot of data that shows that um, flourishing screeners do not capture the or is there like really a big difference between the GAD PHQ-9 scores and these flourishing screenings? Because don't they kind of essentially capture the same sort of information?
I mean, I can understand where you're coming from. I think at least my perception or like from what I was reading, it does seem like PHQ-9 and GAD-7 are like specifically screening for depression and anxiety. Versus these questions are really supposed to be not looking at that specifically, but looking more towards kind of what's beyond that. So I think I I like totally understand where you're coming from. I think, some of these questions of like meaning and purpose and relationship, I think they are somewhat touched on in like the PHQ-9. But I think the the framing of the questions, maybe in these like flourishing measurements, kind of open a different can of worms to discuss with patients than the PHQ-9 and the GAD-7. But to answer your question, I didn't really find anything, any like really concrete evidence on like kind of what the differences between those screenings are and if they like affect outcomes at all. I don't think that area has really been studied.
Do we have any other questions? Let's see. I think you might be all set.
Okay, thank you so much.
Great, thank you so much. We are running a tad bit ahead of schedule, but I do know our Dr. Becker has a 10 p.m. or a 10 a.m. commitment. So if our third presenter, Dr. Morobi, is on board and doesn't mind going a couple minutes early, we can continue. Dr. Morobi, I know you're signed in. Would you be okay with going a couple minutes early?
Yes.
All right, we can see your slides. Let's make sure we can hear you and see you.
My name is
There you are.
Can you see me? Hi, Jane. Can you see and hear me?
Your audio is a little faint, but your slides and your
now.
that sounds a little bit better. Yes.
Okay.
Okay. Let me give you a quick introduction for our third presentation. Doing completed research is Dr. Rorasang Morobi. Hope I said that correctly. With Jackson Park Hospital Family Medicine Residency. For this presentation, the reviewers are Dr. Sarah Reese and Dr. Ava Becker. As a reminder, you have 15 minutes. The clock will begin when you do. I'll give you a quick 2-minute warning in the chat and verbally, and then our two reviewers will have some questions for you when you're finished. Do you have any questions for me?
No.
Okay, well, good luck to you. And once again, the clock will begin when you do.
Okay. Like Jane said, my name is Rory Sang. I am doing a presentation on patient acceptance and adherence to medication assistance, MAT, for alcohol use disorder and opioid use disorder. And this was done at Jackson Park Hospital. So a brief background, Jackson Park Hospital, every 2 years, it conducts a health needs assessment, the community health needs assessment survey. So the last one was the 2023-2024, where it was found that 27% of the participants in that assessment commented that substance use disorder was their concern. This this concern was now in the third position as opposed to the previous one that was done in 2021-2022, where it held 10th position. So this upward trend in substance use disorder in our service area, unfortunately, also mirrors the national trend that has been increasing since the start of the COVID-19 pandemic. According to the Chicago Department of Health, there were more opioid overdose-related deaths in Chicago compared to homicide and traffic-related deaths combined. So this shows the significance and the impact opioid and alcohol use disorder have on our community. And unfortunately, majority of the deaths were in Black and non-Hispanic Black males. Alcohol use disorder in Chicago is higher than the national average, and the rates of alcohol-related emergency department are higher in communities with low household income, which is the catchment area for our hospital. It has been shown that more than 90% of patients who receive medical assisted withdrawal, which is commonly known as detox, relapse within 1 month of detox, as compared to patients who also get enrolled in medication-assisted treatment. It's been shown that their course gets better. They do not relapse as quickly or as much as patients that just go into the hospital for detox. So in the 2024 Community Health Needs Assessment, Jackson Park Hospital mandated itself to work together with the stakeholders to develop strategies that address priority health concerns in our area. So this study stemmed from that to help contribute towards to that mandate to see how we as Jackson Park can get involved in addressing the needs of the community that we serve. So the objectives of this study was to educate participants admitted for opioid use disorder and alcohol use disorder about MAT options and resources available in our community and how such patients can access such treatment. Another objective of this study was to determine how much patients are willing to accept enrolling in MAT, and also to determine how many of the participants after hospital discharge will actually follow up and enroll in MAT for opioid and alcohol use disorder. So the study design, this was an interventional prospective cohort study that was conducted on patients admitted at Jackson Park Hospital between September 2024 and September 2025. And the diagnoses that I was searching for were opioid overdose, opioid detox, alcohol intoxication or poisoning, alcohol detox, and any other medical related conditions to this, to opioid use disorder and alcohol use disorder. The data was collected using questionnaires. This was done in 2 stages, if I may say that. The first stage was patients that were admitted either for detox, for intoxication, for overdose. So we administered questionnaires for this patient to these patients, collected basic demographic information, their substance use disorder, and whether they were willing to enroll in MAT and whether they knew about MAT or not. Then we educated participants about available MAT options, and we provided them with resources that they could use to follow up after discharge. These resources included facilities like actual names and addresses and phone numbers and how to get in touch with such facilities around our community to enroll in MAT. Then after the participants were discharged from hospital, they were followed up over a period of roughly 4 months, each participant over the phone. The first follow-up was within 2 weeks of discharge and then monthly for 3 consecutive months. So this gave it roughly 4 months with the participants. Then data was analyzed using descriptive statistics using a software PSPP to analyze the data. So here are our results. Firstly, we were only able to voluntarily get 37 participants to enroll in the study. Majority of the participants were male, 62%. And of all these participants, as we can see in figure B here, most of them did get high school completed and went on to study beyond high school. But however, majority of the participants were unemployed with no source of income. And the next batch were mostly receiving SSI. There were very few participants that had full-time employment. And then moving on to marital status, as we can see here, most of the participants were single and very few were widowed. And then some were separated, but majority were single. Then participants by admitting diagnosis. This is the actual number of participants. So the highest number was in alcohol intoxication. And then we had participants with opioid detox and those that were admitted just for opioid overdose. Then percentage of patients readmission by diagnosis. So here we were trying to analyze of each admitted diagnosis, how many times you as a patient have been admitted to a hospital, let's say for opioid detox. So a very small percentage, this was their first time being admitted for opioid detox. Majority had been admitted 2 or more times for detox. For overdose, we see a more similar trend with more readmissions. And then for alcohol intoxication, similar thing. So the trend here is patients get admitted for detox, get discharged, and they get readmitted. So what we are trying to do is cut this readmission cycle by enrolling patients in MAT. Then participant awareness about MAT for both patients that were in the alcohol use disorder diagnosis and those with opioid use disorder. So in terms of awareness, for patients that were admitted for opioid use disorder, this will be the detox and the opioid overdose. Majority had heard about methadone. As we can see, very few people knew about Suboxone. Then for alcohol, patients that had alcohol-related admission, none. Majority of the patients for alcohol use disorder were not aware that there is MAT for alcohol use disorder management. Very few had heard of naltrexone, but the trend was generally that alcohol use disorder patients do not know that there is a MAT for alcohol use disorder. Participants admitted for alcohol use disorder were less knowledgeable about MAT, but were open to enroll in MAT programs to manage the disorder. Then we went on to assess whether patients had previously been enrolled in MAT or not. So of the 14 participants that were admitted for opioid detox and overdose, so opioid use disorder, 64% reported that they had previously been enrolled in methadone program, and only one reported that she had previously enrolled in Suboxone. Of those admitted for alcohol use disorder, 42% reported previous participation in a rehabilitation program, 5 previously attended Alcoholics Anonymous, and only 5% were previously on naltrexone. So this shows that patients with alcohol use disorder in general do not receive as much information as patients about opioid use disorder. So then after all that information was collected, we provided education about MAT, and then assessed whether patients are willing or interested to enroll in MAT. On this, the first 2 bars, it's opioid use disorder. Majority of patients were interested in enrolling in MAT. And for those that had been admitted for opioid overdose, some show that they are really not interested in MAT. Then on this last 3, it's mostly alcohol use disorder. They also were mostly interested in enrolling in MAT, and then some reported here under alcohol poisoning that they reported that they are not interested and they are planning on going back to using alcohol again after discharge. Then for both opioid and alcohol use disorder, there were patients that voluntarily brought themselves to hospital. Others were found overdosed and someone called the ambulance and brought them here. So we also wanted to assess whether voluntarily coming to the hospital had an impact on the patient's interest on MAT. So of the participants that voluntarily brought themselves to hospital, 78% reported that they were interested in enrolling in MAT, and a similar number of patients, 75%, that did not voluntarily bring themselves to the hospital were also interested in MAT. So regardless of whether the patient voluntarily brought themselves or someone else called the ambulance to bring them here, with education, they are interested in enrolling in MAT. So then participants were discharged and then followed up over the phone over that 4-month period. So majority of the participants, unfortunately, were lost to follow up. We couldn't follow all of them for the 4 phone call intended period. Of those that were followed up, 43% of the entire study population, 43% were followed up at least once after discharge. That means at least once they answered their phone and information was collected. Of the study participants admitted for opioid detox and overdose opioid use disorder, 43% reported that they had enrolled in a methadone program. 1 participant admitted for alcohol detox followed up outpatient and was started on gabapentin. Only 19% of the study participants in general enrolled in MAT, and majority of those participants were patients with opioid use disorder. Of the 37 total participants that were enrolled in this study, 32% of them had an emergency room visit or were readmitted to the hospital with a similar diagnosis within 60 days of the index admission. This number we got by going back onto the patient's files, and regardless of whether we were able to follow them up over the phone or not, we were able to see whether our study population came to the ER or not. So 1/3 of them came back to the ER with a similar diagnosis. And a majority of this were those that were lost to follow up. So they were not accounted in this number that had enrolled in MAT.
You have about 2 minutes left.
So from this study results, it is evident that patients admitted with opioid use disorder are more knowledgeable about MAT with methadone, more knowledgeable about methadone as compared to Suboxone. Majority of the participants admitted for alcohol use disorder were not aware of MAT. It is evident that regardless of whether the patients voluntarily brought themselves to the hospital or someone else brought them here, with proper education, patients are interested in enrolling in MAT. From this study results, it is also evident that more work needs to be done to provide education to patients with both alcohol use disorder and opioid use disorder about available MAT options in order for us to all win this battle that we are facing. So from this study, here are some of the recommendations that would help all of us to win this battle. MAT should be prescribed to participants prior to discharge from the hospital. Patients should be linked to outpatient care follow-up to continue MAT. Patients with opioid use disorder who are interested in initiating Suboxone should be started on such treatment during their detox time in the hospital. And patients interested in methadone treatment should have methadone clinic appointments scheduled for them prior to discharge, as we know that methadone is only administered in federally accredited clinics. Patients with alcohol use disorder interested in MAT should have such prescriptions started prior to discharge, and those that would want to go on injectable naltrexone should have such medication prescribed prior to discharge. And providers who take care of detox patients at Jackson Park should be encouraged to prescribe MAT to patients prior to discharge and encourage such patients to continue care in the outpatient setting. If I may add, since this study was completed, the hospital has received a grant that is going to enable us to be able to prescribe Suboxone. Currently, we are receiving education. Providers are receiving education about Suboxone. We are working with the bridge program So I believe some of this, we will be able to meet these requirements to help all of us win the battle against substance use disorder in our community.
Great. Thank you so much, Dr. Morobi. At this point, Drs. Reese and Becker, the floor is yours. It looks like Dr. Reese has put a question in the chat, which she asked, I think this is a great topic, and I liked that you had data for the needs assessment of your patient population. I might have missed this, but did you track how many people you asked to participate in the study and declined?
I did track that, but I don't have, I would need to get out of this and get onto another sheet, but I was keeping track of the patients that were saying no, so that since there were multiple of us collecting data, so that each person, even if that the other person is not there, they're able to go onto the sheet and see Mr. So-and-so said no to participating, so that we don't redo the same patients.
Do you have plans for you or another resident to continue with your project moving forward?
I am hoping that I was working with a second-year resident. I am hoping that she may take up the study and do more.
Wonderful. Let's see. Dr. Reese would like to know what would be, she would be interested what the biggest barriers are to participation.
Most patients that I was meeting that were saying no, it was either they were like in the active painful detox phase, like diarrhea, abdominal pain, all those that they were honestly in pain, and I could see that, okay, this patient is not comfortable. But some were, it's very few that were just like, I'm not interested. But most, it's because they were physically not in the headspace to be able to sit down and listen to us for 10 minutes.
We'll hang out to see if either one of them have any additional questions for a moment. As I said, we are running a couple of minutes ahead of schedule, which is never a bad thing. No more questions from Dr. Reese. And I know Dr. Becker has patients to see at 10 o'clock. So with that, I will give my thanks to Dr. Morobi and Dr. Rojas. If you don't mind going a couple minutes early, we can put you on deck. Feel free to unmute and let me know if you don't mind going a couple minutes early.
Hello, good morning. Do not mind at all.
Oh, hello, good morning. Well, if that will work for you, then let's see. I've got our reviewers on board. So if you are okay with that, then allow me to introduce Dr. Juan Rojas from the Rush Esperanza Family Medicine Residency Program with his in-progress research project. And reviewers for your presentation will be Dr. Meredith Gray and Dr. Addison Montgomery. Just as a reminder, you'll have 15 minutes to present your slides. You'll get a 2-minute warning in the chat and a quick one in verbally to let you know when you need to get close to the end. After you complete your slides, the two reviewers will either ask verbally or put a question for you in the chat. If you have any questions, now's the time. Otherwise, I wish you luck and the clock will begin when you do.
Okay, thank you. Good morning, everyone.
Good morning.
I have Dr. Lisbeth Garcia here as well with us. Dr. Elisa Garcia is also seeing patients this morning, but she was part of our project as well. We're going to be talking about a project on implementing a patient-held health passport to improve health information access in diabetes care at an FQHC. We are part of the Rush Esperanza Family Medicine Residency, and we'll get started.
Awesome. Well, good morning. Good morning. Thank you, Juan, for the brief introduction. I'm Lisbeth Garcia. I'm, like he said, part of the team doing this QI project. So just a little bit of background here. Esperanza Health Centers is an FQAC that serves predominantly Latino patient population with high rates of chronic disease, especially diabetes, cholesterol, high blood pressure, etc. So one of the biggest barriers we identified was access to health information. About 56% of our adult patients were not enrolled in the EMR patient portal, which makes it harder for our patients to track their chronic diseases, goals, and understand their care. We also recognized barriers related to language, digital literacy, and fragmented care, since most of our patients travel and receive care elsewhere. And since health literacy is closely linked to adherence and outcomes, we wanted to explore a simple and accessible intervention. So we created our low-tech patient health passport to help our patients better track and understand their diabetes care. While electronic tools can be helpful, they often depend on digital literacy and access to technology. So we wanted to see whether a physical tool could be a more feasible option for our patient population. I'm going to leave it to Juan for methodology.
Absolutely. And then did want to mention that this continues to be used internationally. We see some of our patients even at Esperanza who come in from other countries, and they have, sometimes they will have, and it's nice when they do, health passports that tell them about their immunization history. They might talk about obstetric history, and they continue to be used. And one of our residents, Dr. Elsa Garcia, used to practice in South America, and where she practiced, they continue to use them as well. But there's less data on this in the last 10, 20 years here in the US. So for our methods, if while we talk about our study, you may see some elements that seem more like QI and some elements that seem more like your more typical research studies. There's a reason for that. We originally intended for this to be a more classic research study. We went through, we were asked by the IRB at Rush to do a full review because we were tracking patient information. That took about a year of creating the required materials for the IRB, getting the revisions, editing them to meet their needs. But we quickly, after getting IRB approval, we quickly realized that although implementation was going fairly smoothly, we saw some elements or some ways that we could improve. And really only a QI would let you do that as you go. So we're doing this now. We're transitioning fully into a quality improvement project using PDSA or Plan, Do, Study, and Act cycles. Our participants are adults aged 18 to 90 with diabetes receiving care at Esperanza, specifically at our site, and specifically only our patients right now, as in me, Dr. Lisbeth Garcia, Dr. Elsa Garcia. Only our patients are being enrolled. We are using a physical health passport. We will show an example on the next slide, and a baseline survey that we provide to the patients during regular encounters. So we identify patients who are 18 to 90 with diabetes while we're going to see them in our own continuity clinic, and we try to find the time to get them into this study or into this project. The plan is for follow-up surveys to be collected after at least 2 follow-up visits or 6 months, so we don't have that follow-up information yet. And our outcomes are mainly right now responses to surveys and the use of the health passport on return visits. These first PDSA cycles are aimed at assessing baseline patient characteristics, assessing feasibility, and improving implementation. Future PDSA cycles will focus more potentially, if things go well, if we see that it does meet, that it is feasible and implementable. We might move more towards seeing if we can affect patient outcomes. Can we actually have patients who are more adherent to their visits, or potentially even see if there's any differences in A1C for patients who do or do not use this passport. Here is a picture of the first couple of pages on the inside of the health passport. The outside is all branded with Esperanza. It was done with their marketing department and the approval of CMO and the quality improvement team there at Esperanza. Originally, this was going to be to track as well things like hypertension and high cholesterol. So that's why you'll see as well blood pressure and LDL on the form.
Yeah, awesome. And just like Dr. Rojas mentioned, the main goal of the first PDSA cycle was really to evaluate feasibility, patient engagement within a busy clinic flow. So our first PDSA cycle from October through December of 2025, we started by giving patients a short baseline survey. We asked questions about their understanding of diabetes, what A1C means, and whether they knew their personal A1C goals. After that, patients received the health passport, and were educated on how to use it during clinic visits and at home. We also encouraged patients to bring their passport back to their follow-up appointments, and that was like a point data for us.
Here are some of our results through March. So through March, we had 18 participants who accepted the health passport. And these are their survey responses. So the top left, and again, these are just self-reporting. Do you believe you understand? So this isn't even getting into actually like quizzing their knowledge in any very specific way. But we do see something important here in these already in these answers. So how well do you understand what diabetes mean? Most of them answered very well, and then only 4 out of the 18 said not at all. But when we then asked them, just do you know what A1C means? Not quizzing them on what it actually means, just do you think you know what it means? 9 of them or half of them said not at all. So definitely something that was very eye-opening for us as a team. And then even more so, do you know what your goal is for your A1C level? So we feel like we spend a lot of time as residents, as physicians, explaining A1C and goals to patients. We have handouts at Esperanza that a lot of us give to our patients about this goal. But even with that, 15 of the 18 said no, they do not know what their A1C level goal is. And again, that's not quizzing them on what it is. That's just asking them yes or no. Do you know what your goal is?
And a little bit more about the results. So through March, 18 patients, like Dr. Rojas says, had received a health passport and completed the baseline survey. Of the 6 patients who had returned for follow-up visits, 4 brought their passport back with them, while 2 did not. At the time of data collection, super important, 12 of our patients were still pending follow-up visits. Even with this small size of a sample, these early results were encouraging because they showed that patients were willing to engage with and use the tool over time as they were bringing them in and asking questions. And it was, again, really eye-opening for us as a team.
And then so PDSA2, we called it PDSA2 because we made a change to it. And so this is when we started to transition more to a formal QI. So what we saw was this was an opportunity based on the patient baseline surveys to include more education and for giving the patient the physical health passport to not just be extra to the visit, but to be truly part of the patient's care. Thankfully, Esperanza had already had compiled quite a few documents through community health workers, care coordinators, and other physicians and APPs before us, from the CDC, from the FDA, from the federal government before maybe we could trust it a little more. The handouts include information on A1C, diet guidance, and warning signs for hypo or hyperglycemia. And then we are still currently in the process of reviewing the differences that we've seen between us 3 in terms of implementation, enrollment, and follow-up. For example, we don't have this data here, but Dr. Elsa Garcia, almost all of her patients accepted the book, as in the ones that she asked to be involved, they took it. And all of her patients so far, of those 4, I believe 3 of them were her patients who brought them back. So we have to see what she's doing well. We're meeting with our QI leaders at Esperanza and our CMO about every 3 to 6 months to make sure that as we look forward to future cycles or implementation, that we discuss with them if this can be scaled at all. And then meeting with the leaders and managers of other departments like the MAs or the care coordinators to see how they can be involved and make sure that we're not overstepping their work descriptions. So that is where we are right now.
So briefly, in conclusion, our first PDSA cycle showed implementing this health passport that is patient held for diabetes was feasible. Our patients were willing to bring it back and interact with it, and were more than happy to get it and use it as a tool. Our baseline surveys also revealed an important gap, just like Dr. Rojas mentioned previously. While many patients felt they understood diabetes overall, fewer understood A1C specifically meant or knew their own A1C goals. Because of that, PDSA Cycle 2, we added Spanish accessible diabetes education handouts to help reinforce education and improve understanding. Overall, our project suggests that meaningful interventions for chronic disease management do not always need to be high technology through our EMR or other processes, but using more low-tech, simple tools that are patient-centered. These may still play an important role in improving engagement and continuity of care.
And then for future directions, and also discuss some limitations here again. So continuing to study in action of PDSA2, we want to draft a second version of the health passport with simplified instructions on its use, because that was one of the things that we saw between us 3 that made implementation difficult. And then also integrating EMR registration information, because we don't want this necessarily to replace the EMR. We hope that it points patients to use that. Maybe the hope is that if they see how well they're able to manage their care with the information in a health passport, maybe that'll incentivize them to go and register for the EMR and have access to their lab results there. And again, like I mentioned before, continuing to assess the ability of having support staff involved and minimizing the burden to any other physicians or ABPs that use the passport in the future. And then identifying issues with data management follow-up. We use Athena instead of Epic in the clinic. Epic has things like slicer, dicer, and patient lists, things that Athena just does not have implemented. So our data collection has had to be very low tech as well, just using physical forms that stay in-house at Esperanza or a secure SharePoint. And then our hopes for PDSA 3 and onward will be that we can assess if it's efficacious. Do we feel like patients are satisfied with it, that they're getting something out of it? And then continue to assess feasibility to scaling. And if we see that patients are satisfied, they're using it, and that it's feasible to scale, maybe considering monitoring or measuring more direct patient outcomes like visit attendance and A1C. And then PS, all three of us on this team are actually staying at Esperanza, so we will get the chance to continue this work and potentially involve future residents, or potentially do something similar, low tech, but completely different if we see fit. That's the beauty of QI, I think. We just want to acknowledge Dr. Emma Warringer. She was our faculty member here. She has moved to greener pastures since, but she was a lot of help, especially with the IRB. Dr. Anna Nguyen has taken over, and we thank her. Dr. Kim, our medical director, our medical officer at Esperanza, and Sam Ross, who's part of the QI team there, and really just everyone who's helped us at both Rush and Esperanza. Here are our references, and we will take any questions.
Thank you both for your presentations, and congratulations on your future plans, joining faculty and being able to continue your work. We are always happy to hear when our graduating residents are staying. Both reviewers have posted questions in the chat. Dr. Reese, should I get the first one? Between PDSA 1 and 2, this question is from Dr. Montgomery, did you repeat the baseline survey, or do you plan to repeat those in the future?
Yes, so right now, we just haven't repeated them because patients haven't come back for that second follow-up visit or the 6 months. We started this PG at the end of PGY1, so 2024. From summer of 2024 to summer of 2025, we were working with the IRB, so we were a bit behind our timeline of what we wanted to be, but that's why there's no follow-up information right now. I'm not 100% sure. We're not 100% sure how much surveys or individual data collection will be involved in the future as we transition to QI. But with our IRB protocol that was approved, that's what we have permission to do, is to get those repeat surveys after either after at least 2 visits or 6 months.
And the second question is if there is any way to increase the number of patients involved in the study. Is there any way to increase the passport usage? 4 out of 6 is about 66% follow-up rate.
Yeah, I think the answer is similar to that too. Yes, we definitely need to. Us three, one of the things we're trying to do in PDSA 2 here is better standardize how we are enrolling patients. When we see 11 patients in a half day as residents, we have to precept them. So as we have gone up in the number of patients we see per half day, it has gotten more difficult. So that's something that we really need to work through. And then secondly, to the usage, we do think a lot of that is still just the time. So if a patient, even a patient with uncontrolled diabetes, we may see them every 3 months, and that's in an ideal scenario. We have a lot of patients at our FQHC that unfortunately can maybe come and go as they're able.
And also, Juan, if I can piggyback on that.
Please.
We also, as residents, have like limited clinic time. We do about two days in a week. So that's going to change a little bit in context when we move from residents to attendings, and we're going to be more time in the clinic and more time to standardize the process and also see more patients and be able to get more patients in to use the passport.
Fantastic. Just looking to see if there were any follow-up questions for either one of you. And we are still running about 10 minutes ahead of schedule, which is always a good thing. But I do believe our 5th presenter, Dr. Zatina Huesca, is already on board. If you are okay with going a couple minutes early, I'd be happy to keep the ball rolling. Dr. Zatina Huesca, you okay with that?
Yeah, that's totally fine.
Okay, well, with that being said, just allow me to introduce you. This is Dr. Joaquin Zatina Huesca with the Rush Esperanza Family Medicine Residency Program as well, with his In Progress project to present. And reviewing this presentation will be Dr. Sarah Reese and Dr. Addison Montgomery. Just so you know, you will have 15 minutes to go through all your slides. I'll give you a 2-minute warning in the chat and a quick one verbally, just to let you know. And then once you complete your presentation, our 2 reviewers will have questions for you. We can see you, we can hear you. We're just waiting to see your slides. Do you have any questions for me in the meantime? There's your first
Are you
slide.
able to see my slides?
It's there now. So otherwise, welcome and we wish you luck, and the clock will begin when you do.
I'm sorry, were you able to see my slides? You said yes?
Yes, we can. Looks good. Thank you.
Okay, perfect. Well, welcome everybody. Thanks for having me here. Good morning. Dr. Zatina Huesca, also from the Rush Esperanza program, as my previous colleagues mentioned. We are affiliated with FQHC, and my presentation is the chilling effect of immigration enforcement. Being from the Chicago area, as you all know, we had some immigration enforcement recently, and it affected several of our patients. We actually saw a lot of movement in the areas that we have clinics, and I wanted to actually run the numbers by to see how that impacted our appointment adherence and telehealth utilization. I worked with Samuel Ross, who was the director of quality. And for those of you who are wondering what is the chilling effect, this is the policy enforcement that happened last end of the year from the federal agents here in the Chicago area. And that created a lot of uncertainty, a lot of fear in the community that we serve as physicians. And we understand that this has happened in other areas, and it disproportionately affects vulnerable populations. Particularly in the Chicago area, was what they call the Operation Midway Blitz. That was heightened immigration enforcement. We saw a lot of federal agents that were around the community. They expanded detentions and enforcement operations. This again happened mid to late 2025. It is, I understand, still happening in some areas, not as visually or not as visually prominent as we saw that period of time, but definitely created a period of uncertainty, perceived risk, and then reduce public trust in institutions. Luckily, with Esperanza, we've had a good relationship with the community. We were able to mobilize a lot of the staff, and the staff mobilized themselves as well to provide resources and information for our community members that were undergoing the stressful times. My objective was to definitely evaluate the changes happening between these 2 periods. We compared to the baseline, which was September to December of the year prior, and we wanted to make sure that we wanted to compare the appointment adherence, cancellation patterns, telehealth utilization. This is a retrospective analysis, and we wanted to compare, like I mentioned, year over year to make sure that we assess for controls, basically. We did no-show rate, cancellation rate, telehealth share, and we ran some statistical tests. Overall, we saw in 2024 110,000, a little bit over 110,000 appointments, which were very comparable to 2025. There was minimal change, so it was overall stable when it comes to comparing these 2 patient populations. And for the metrics, the no-show rates was the no-show appointments over the total, cancellation rate, telehealth share, like I mentioned there. The 3 subtypes that are important here are these cancellations that were driven by the patient. We have a system with Athena where the patient can communicate with Esperanza, and they have a patient portal. Those cancellations, we also have our staff contact the patients via text messages. That was also taken into account. And then patient initiated cancellations, that's when patients themselves called or showed up or they didn't show up but canceled via phone. Overall, we saw that the no-show rate increased a little bit, and then the cancellation rate as well. And there was a small increase in the telehealth share, but the missed appointments increased the most. Again, these numbers were expected, but we wanted to make sure and we had a visual or actually analysis of what actually went down. You can see here we have a graphic representation of the cancellations of the year 2024 compared to the year 2025. We see here on the first graph on the left, that year 2025, there's an increase usage of telehealth, again with no-show rate on the graph on your right. And same with overall cancellation rates and telehealth. So 2025, we saw the telehealth slightly elevated but stable compared to the year prior. And the pattern was consistent. It wasn't necessarily, when it comes to telehealth, it wasn't like a particular spike, but we did see a lot of no-show rates and cancellation rates. So we relied mostly on the telehealth in order to take care of these patients. We also saw a decrease in patient portal-driven cancellations, but the text message cancellations, which were more, those are the ones where we send a text message to the patients, that increased slightly. So overall, it was more of a shift from system-driven to patient channel-driven behavior. As you see the graph here on the right, you see that the patient cancellation rate was overall the same, but again, from prior, like patient system-driven, basically from our patient portal or places where we call the patients because the providers, for whatever reason, are not able to see patients that day. That was about unchanged, and we saw a lot more, like I said, patient-driven cancellations. Excuse me. So overall, the rate of no-shows, cancellations, and text message cancellations was significant, and there was again a decrease in the patient or the system-driven cancellations. But overall, the cancellations were not significant. Like patient canceled at a similar rate. It's just the way they canceled changed. More patient-driven. We also wanted to stratify findings based on insurance. As you see on your graph to the right, we see that uninsured patient no-show and overall cancellations increased for uninsured patients, also with Medicaid patients, and then we had a smaller effect on patients that were privately insured. So we see that vulnerable populations were disproportionately affected during this period. So overall, we have these findings suggesting, overall increase, with no overall increase, but missed appointments by uninsured Medicaid populations and also by patient-driven cancellations. So we saw that behavior shift in the cancellation pathways, which are consistent with this chilling effect on the healthcare utilization. My limitations were this is observational, obviously not causal, but also we didn't check immigration status. We don't ask for immigration status. We don't that's not ever documented anywhere. So that we are just solely going by the data that we have, which are usually uninsured, under or patients on Medicaid, which usually people who are undocumented are not able to qualify for Medicaid or Medicare. And then we also have some possible system workflow changes given the stress in general. And then again, this is just from Esperanza or from Athena or our EMR. So overall, the no-shows and cancellations, patient-driven no-shows and cancellations increased significantly from the patient-driven, and then telehealth minimal compensatory increase. So we're basically consistently seeing patients on telehealth, but definitely our vulnerable populations were mostly affected. And then we can see how policy environments that are currently happening in the whole country can indirectly reduce healthcare access. And that is something that we are very passionate about here at Esperanza, making sure that everybody gets access to healthcare. But unfortunately, we are currently lobbying, or we go down to Springfield and we lobby to advocate for our patients and all the policy changes that are happening. So implications, we definitely need to target our interventions when it comes to seeing who our patients' populations are and how we can directly help them. Esperanza did a lot of outreach during that time as well, make sure patients were okay. During COVID as well, Esperanza was one of those that made sure that patients that were not having enough information, things like that, their system set up that they were able to put that information out there for our patients. Trust building strategies, make sure that patients feel comfortable going to an institution, make sure that they feel that the institution has their back, that they are protected when it comes to things that are happening around them. Also expanding healthcare telehealth options. We have an easy way to making sure that patients have access to us via telehealth or even phone calls. Flexible scheduling. We just currently expanded our hours to make sure patients have different options as well. And then someone monitoring these impacts that are happening, because I feel like everything is happening, being talked about, but not statistically shown, and be able to prove that these things are actually affecting the health directly of vulnerable populations. And are there any questions? It would be.
Great. Thank you so much, Dr. Zatina Huesca. First, let me give you a clarification question from Dr. Montgomery. When you say missed appointments, is that a total of missed appointments and the cancellations, like no-shows and advanced cancellations?
Yeah. So yes, I apologize. I guess that makes sense that cancellations. So appointments that were scheduled but they didn't happen, basically.
Dr. Reese says this is a great and important topic. Were you surprised by the results? Was the effect on cancellations and no-shows smaller or larger than you expected when you started?
It was definitely smaller than I anticipated, because I feel like a lot of anecdotal experiences of the providers that were experiencing no patients no shows and things like that. It seems like it was more than what the data actually showed. But I do realize that Esperanza, like I mentioned, they really made it a point to have all the patients still have meet their healthcare needs. And so I think that was a little bit of a surprised that it was less than what I expected, but on the same time, I was thinking of what good of a job Esperanza did to make sure that patients still had all their care during that stressful period.
I'm going to provide one more question from Dr. Montgomery. Talking about the breakdown of the total of Medicaid versus self-pay, on the face of it, the change does not seem too large, but is certainly exaggerated in the subgroups. What is one intervention you would make to the clinic based on these results?
I think one of the biggest changes is to provide information to the patients that we are able to, because a lot of the times the patients come in and they say that they've missed appointments because their insurance has been canceled, or there've been changes in their insurance status that they stopped coming. And I think that's something that they don't understand, that we as the FQHC, we actually see everybody regardless of their insurance status or immigration status. And I think that's something that they don't, it's not like a general it's not like a general knowledge for our patients. So I think we should have, definitely have ways to provide that information that, hey, you're able to come regardless of your insurance. Already provide like a sliding fee scale. Go ahead.
And you had mentioned that that the clinic doesn't ask anything about immigration status. So did you just have some like general messaging, and how was that, so that no matter what, everyone knew that it was safe to maintain your
mostly
appointments?
Yeah. Well, I think I think what worked in this scenario was that Esperanza has had a community presence for a long time. A lot of our staff members are most of them are Spanish speaking, same with our providers. And so I feel like in a way we've already established that trust, and patients knew that they were safe at Esperanza to be able to come. Again, I just don't know why there's a little bit of lack of understanding that we take everybody regardless of insurance. And I think a lot of what happened was also recent immigrants that come in and they're trying to get used to the new system, and they've been told that they need insurance for healthcare in general. Maybe they don't know that these places provide that service. There was a period briefly where they provided state insurance, and then that recently changed last year with a change in changes in administration. And so a lot of them, they had insurance initially, they lost it, and then they thought, oh, well, I don't have any more access to healthcare because I lost this temporary insurance, but I just don't think they have the information.
I think that are all the questions from our presenters. So, or from our reviewers, I should say. So with that, I'd like to give my thanks to you, Dr. Zatina Huesca, for your presentation. We are still a couple minutes ahead of schedule, but Dr. Gonzalez Alvarez, if you are on board and okay with going a couple minutes early, please let me know and we'll keep on moving.
Hi, yes, of course. Let me share my presentation.
All right, while you are getting that ready, I will introduce you, Dr. Anibal Gonzalez Alvarez, also from the Rush Esperanza Family Medicine Residency Program in Chicago. He's got a completed project, and the reviewers for this final presentation of this very busy first block will be Drs. Meredith Gray and Dr. Sarah Reese. You will have 15 minutes to present all your slides. When you get down to 2 minutes remaining, I'll give a quick note in the chat and a quick verbal, you have 2 minutes. That'll give you your cue to get towards the end. And then Drs. Gray and Reese will have questions for you either in the chat or they'll unmute themselves and ask. If you have any questions, I can see your slides. We can see you and hear you. If you don't have any questions, then I'll just wish you luck and the clock will begin when you do.
All right, perfect. Thank you so much for that introduction, and thank you all for having me. My name is Anibal Gonzalez. I'm a family medicine resident, PGY3 as well here in Rush Esperanza Family Medicine Residency, such as, all my colleagues for the past 2 presentations here at Rush Esperanza in Chicago at an FQHC. So my presentation is more about educational elective that we implemented and how kind of like that will influence the residents' teaching skills in any way. So without further ado, the rug is pulled and you're now the teacher. Let me see if this changes. All right. So what are the objectives of this presentation? So to describe the structure and implementation of residents as teachers at an FQHC in Chicago, to identify the impact of precepting elective on resident confidence and teaching skills, and then to discuss the potential of integrating a precepting elective as a core rotation, which is kind of like the main reason why I decided on this project was about this elective and implementing it as a core rotation rather than just an elective, basically making it a core rotation. So what are the background before we begin? As we all know, family medicine is a very challenging specialty to teach and master just because there is so much that you have to do. And I think, thinking back to all of my mentors in medical school and even residency, most of the teachers that you have tend to be family medicine physicians. So I think that's a very good skill set for us to have as incoming faculty and colleagues. Residents as teachers programs typically do have residents teach medical students, but our precepting elective itself focuses more on residents teaching other residents rather than medical students. And here we'll follow this implementation of the precepting elective at an FQHC in Chicago, and then we explore the outcomes of this elective and we'll evaluate the confidence of family medicine residents. So kind of like what is the elective background or what does the elective look like? So it is a 4-week elective in which and you'll see a breakdown later on, in which there is parts of it which are self-directed learning where we are kind of like engrossed in all these teaching paradigms. And I've included one here, which is the 1-minute preceptor, which is honestly my favorite one, being at an FQHC, a very busy clinic where I think Dr. Rojas said earlier, we see 11 patients in a half day. So kind of like when you get PGY1s, PGY2s coming into your precepting and you're now the preceptor, you really want to be able to get as most as you can from a PGY2, PGY1 in 1 to 2 minutes. So that self-directed learning is kind of like learning all those teaching paradigms. And then there is also part of it, which is actually precepting with residents. So a little bit of background of also like what do we know? So I came across this like study, 2014 SIRA study. It did show that it was basically a survey for many family medicine program directors around the US. And it showed that an average of 7.72 hours during a whole 3-year residency are devoted to teaching skills, which I thought was a little small. But we do turn to learn a lot on the job. While our precepting elective at Esperanza, it is 120 hours of clinical precepting, so just dedicated to your teaching skill overall. And then there's 72 hours of self-directed learning where you are kind of like reflecting and also learning about all these paradigms, learning on better ways to teach residents, and to also get the most of them, and also to give feedback, because getting feedback is pretty difficult. And then these are the questions that we'll answer. So will it increase the confidence of family medicine residents in teaching? And should it be a core rotation at Rush Esperanza Family Medicine residency? And so the methodology, pretty small sample size. We have 4 residents that have completed the elective. We are a pretty new program. We are going to be now the second graduating class. So 1 graduate completed it last year, and then 3 current PGY3s completed this elective this year. The way we did it was we developed a survey from Roat et al. About a post-elective survey. Was unable to do a pre-elective survey. I'll talk about that later. And then the participants filled out the survey about, and it's right here, about 4 to 6 months after the elective for PGY3. So after they had already kind of like done it 4 to 6 months ago, and a whole year after our graduate did the elective. So pretty far away from when they actually did the elective. And then the data was collected and analyzed. So what the survey looked like, so I don't have the exact survey here, kind of like did a broad overview of what it included. So basically 5 categories that I gave to all my fellow colleagues and the graduate, the attending that's there that graduated. But basically, there were multiple questions from these different categories being precepting competencies, feedback and assessment, teaching attitudes and beliefs, assessment of clinical teaching skills, and learning environment. And then all were answered on a scale from 1 to 5, being 1 like not at all confident or strongly disagree, to 5 being extremely confident and strongly agree. So an example of one question was, do you believe, like Rush, do you believe the precepting elective should be a core rotation? Or do you think that doing this precepting elective improved your efficiency in clinic? So it was a lot not just about teaching, but also about yourself as a physician. And here are some of the results that we found was that 100% do strongly agree that teaching fellow residents enhances your own clinical learning. 75% strongly agree, 25% agree that precepting elective did improve their confidence in teaching other residents. And 75% strongly agree and 25% agree that precepting elective will make them an asset in their future workspace. And then 75% strongly agree that their confidence in differential diagnosis management increased. So these are not all the results. These are just highlighting some of the results that I found the most interesting. Just because we can see here that it definitely did improve, your own learning, teaching other residents, and everything. And then these are 2 other results. One is answering the question that we had in the beginning. So 75% agree and strongly agree that precepting elective should become a core rotation at their family medicine residence program. The other one's because one of the participants answered neutral. So that's why it's 75% agree and strongly agree. And then 75% plan to pursue an academic career involving teaching. And we'll discuss in a second why that's important. Actually, we'll discuss it right now. So one of the things that this is important is because if you do this precepting elective, will you then pursue an academic career in teaching? And once we go our limitations, so we didn't really do a pre-survey just because it was so far ahead. We just did the post-survey, but one of the limitations is definitely recall bias because it was after the completion of the elective, like many months after and a year afterwards. A sample size, it's actually 4 residents, not 3. That does limit the statistical power of this study. And then for future direction, I would consider incorporation the core rotation with properly pre and post time survey for all senior family medicine residents. If we go back here, I think this one in particular about the 75% plan to pursue an academic career involved in teaching would be very interesting to know if a resident before the precepting elective had no desire to go into academic career, whereas afterwards maybe it improved. So that would be interesting to kind of like evaluate later on. And in the conclusion of my project, so the precepting elective did effectively increase the confidence of family residents in teaching. Further surveys should be provided to all trainees immediately after to minimize recall bias, like we said. And I would recommend that, if ongoing projects, let's say next year or the year after, continue to yield similar results, I do recommend adding it on as a core rotation rather than elective, just because it is very helpful, not only for teaching skills, but also for yourself. You know, you have PGY1s coming to you, PGY2s coming to you. It's something you're not really used to kind of like teach them all one after the other in clinic. So you're precepting, you know, sometimes you're seeing even more than 11 patients, which is what we're kind of like used to now as PGY3s. Thank you. And these are my references. Any questions?
Thank you, Dr. Gonzalez Alvarez. First question is from Dr. Reese. Interesting topic and something we have considered at our program as well. Have you surveyed the wider residency to ask about their interest? I'm guessing there is some self-selection bias as in those who chose to do the elective.
Yes. Thank you so much for that question. I do agree. There's definitely self-selection bias because only 4 of us have done it. I have not actually done a survey to see if there's any interest in it. That would be a great survey to add to the current survey maybe for next year. So thank you.
With the next class starting up
Yeah, for sure.
in July.
Yes, I did. Oh, sorry. I did tell them a lot to try to like do it because it is really good and it is very helpful.
Excellent. Dr. Gray would like to know, was there any structured precepting education outside of 1-minute precepting given to the resident during the elective? If not, do you think this would be helpful?
Yeah, so we also learned about the SNAP paradigm teaching elective. The 1-minute precepting is kind of like the one that I most was interested in. And honestly, the time that we have is kind of like the most that we were able to implement. But mostly it was just 1-minute preceptor and the SNAP teaching methods. There were others that were taught as well. I didn't really delve that deep into them personally, but it is you know, when you do those 72 hours of self-directed learning, there are many modules and many different research articles that you read about education and how to give feedback and also how we can further teach residents, you know, during precepting clinic, which is just a skill that we kind of like don't really develop that well. So it's, I think, very helpful.
Excellent. I'm going to hang out just for another minute and see if there was any other questions. Dr. Gray looks like she's all good. And Dr. Reese says she's good. So with that, I'd like to thank you, Dr. Gonzalez Alvarez, for batting cleanup in our first block. You can stop sharing your screen. I will run through just a couple quick things.
Thank you.
First, here we go. I will share my screen. And here we go. So thank you to all 6 of our first round of presentations and our 4 reviewers, Dr. Gray, Dr. Montgomery, Dr. Reese, and Dr. Becker for all your help in reviewing each presentation. So what's at stake? We have bragging rights for the top residents, and the top scoring presentation in the completed projects and in the in progress research category will receive an Amazon gift card, which was provided to us by Healthcare Associates Credit Union. So we thank them for their support of not only this event, but many other IFP events as well. And also, for those of you who have been on, we thank you. You also have the opportunity to review us on Google. I put in the chat a link, and there's also the QR code. Google reviews help to elevate the IFP's profile, so we would appreciate your feedback. And then the credit claim for our physicians who would be claiming CME credit, or if you just need to document your participation today, you can use that link to the CME claiming credit form. Just a reminder to our reviewers to submit your comments and your scores by the end of the day today. Our goal is to compile them all and share them back to each presenter, each lead presenter individually by end of day tomorrow. We thank everyone for being here today. That will wrap it up for our first block. We will be back at 11:20 with the next round of presentations. Thanks, everyone. Okay, welcome to our second block of today's Scholarly Works Virtual Summit. We have 4 presentations scheduled for this block. Before we can get to that, allow me to share with everyone our diversity, equity, and inclusion statement, and that we hope that today's presentations and today's activities live up to those expectations and values. We did do our CME disclosure earlier this morning. Just letting you know that this activity has been approved for 3.5 PRA Category 1 CME credits. That's if you attend all 14 presentations. Otherwise, please report your CME based on the presentations that you viewed today. Also, you will need to use the CME reporting for reporting CME or for getting a certificate of attendance. You will get that link in the chat several times and also at the end in your follow-up email. And then just a couple of little events on the horizon that you can see. Our silent auction for Savannah Bananas tickets closes on July 12th. Bidding is still open. And last I checked, the top bid is $420. And don't forget about the Family Medicine Midwest Conference coming up in September. Online registration is open till August 30th. We're also doing an upcoming town hall, an upcoming CME program on the new Terminally Ill for Patients Act, and we welcome you to sign up for that. All these are on ifp.com. And then what we'll do now is welcome our first presenter for this block. And how this works is each presenter will have their screen ready to go with their slides. They'll have 15 minutes to present and then get a 2-minute warning as they get closer to that 15 minutes. We have 2 reviewers scheduled to observe, score, and ask questions at the end. They have fake names, so if you've been watching The Pit, you may recognize some of these names. They'll ask their questions, and then we'll move on to each presentation in this block. What's at stake for today? Bragging rights, of course, and then the top scoring presentation in each category, completed projects and in-progress research, will receive an Amazon gift card. I want to thank Healthcare Associates Credit Union for donating those gift cards and for all their support in any IFP activities. All right, now let's go on to the presentations. I'm going to stop sharing my screen. And then please welcome Dr. Kelsey Tandon. If we can make sure we can see you and hear you, and you can share your slides. With this presentation, I'm going to introduce Dr. Kelsey Tandon from the U Chicago Advent Health Hinsdale Family Medicine Residency Program. Her presentation is a completed project, and the faculty reviewers for this one will be Dr. Frank Landon and Dr. Heather Collins. I think everyone is here, and let's make sure we can see and hear Dr. Tandon.
Hello.
Oh, there they are, both of you. And
Yes.
Dr. Bomavetti, Dr. Shravya Bomavetti.
Yes. Yeah.
Great. Glad to see you're both together. Welcome.
Thank you.
You'll have 15 minutes to present your slides, and then you'll have to field some questions. Otherwise, we'll go ahead and share your screen. We'll make sure we can see your slides.
Okay. Let me go back. Is it showing them as like unknown? No. Sorry, there's a bunch of, they're not having names, so they're looking kind of funny. Let me test a couple. I'll zoom. Oh. Oh, okay, let's see. Okay, that looks better. Sorry, I had to do a little update.
Okay. All right, we can see them. So from this point, the clock will begin when you do, and good luck.
Okay, thank you.
All right, hi everyone. I'm Shravya, and this is Kelsey.
Hello.
And our presentation is called Assessing Inbox Management, Analyzing Response Times for Test Results and Phone Calls at Hinsdale Family Medicine Center. So to begin with, we have no disclosures. So to give some background, inbox management is becoming an increasingly important part of primary care medicine. And with that, patient portal access is now becoming a norm for a lot of offices, and many offices have a set response time period. In terms of our clinic, ours is a 72-hour response period that they like to see. You're also starting to see offices that are even tying like financial compensation and performance evals to this policy to encourage adherence. Delays, they can not only lead to like patient frustration, dissatisfaction, but they can also cause safety issues sometimes and even medical legal problems. So for this reason, practicing efficient inbox workflow during residency not only keeps us compliant, but it helps us get adjusted to the higher patient volume that we'll have and some of the expectations we'll have in the workforce after we graduate. So with that being said, our question for our project was, how well do our resident doctors follow a less than 72-hour response time to patient results and patient calls, and what effect does information about the importance of timely response have on adherence? So to start with our methods, so we collected data from June to October of 2025. For the month of June, we had all 3 classes of our program, and then after the third years graduated at the end of June, we took the new incoming second and now third years from that July to October period. We had residents share their inbox with us on Epic, and we had a rotating cycle and about twice per week, actually at twice per week, we would randomly take a resident from each class and look at the data for them. So we were specifically noting the number of results and patient calls that were present in their inbox that were there for at least 72 hours that didn't either have like a response with the results themselves or somewhere in the chart there wasn't a note or something indicating that had been addressed. In terms of what we specifically made note of, it was the date we accessed it, the resident's name, what class they were, what rotation they were at, and then of course like the number of results or patient calls that were pending. In terms of our intervention, so we emailed our residency, and then we have like a WhatsApp group message for our residency where we send important updates. So we sent information on both of those, talking about the importance of inbox management, both in residency and after graduation in our jobs, and some of the ramifications that you could have with poor management. And that was done towards the end of September. And to give a general overview of results before we go in there, so in addition to seeing if there was a significant result with the question that I proposed earlier, we also wanted to see if there was any sort of correlations that could lead to better or worse inbox management. And then also there was one outlier with our study, so we will show you guys data with and without the outlier just so we have a better idea of what's going on as a whole. So this is based off of residents. It's the total average. So at the bottom here, we have each resident. They are ID'd, so 1 through 27. And then we have the results that weren't responded to and the patient calls that weren't responded to within 72 hours in general. So this is an average of like basically hitting each resident's inbox 4 times in total during that period. So it's an average of 4. However, I will say like the group that graduated at the end of June, we weren't able to do all 4. So outside of that, it was everyone 4. As you can see here, so the person whose number 16 was the outlier that we were talking about. They are the one in like future graphs and things we talk about that we'll kind of exclude just so we have a better picture. Outside of that, there was only a couple that were really above 10. For the most part, people were like under 5 for items not responded to, and there were even a few residents you can see that didn't have anything that went over that 72-hour period. And now this is the data based off of date. Again, this includes all of the residents. And so in general, with the last graph and with this one too, you can see that result in terms of like results responded to in 72 hours is a little higher than the patient calls. And specifically looking here, there's like 4 dates that are a little higher than the others. And looking back, we were trying to see if there was anything that could kind of, in terms of the residency that was going on, that we could equate to this, and nothing really came to our head. It just looked like intermittently we were seeing a little increase every few weeks. But then we look at this chart, and so this is the one without our outlier, so that the resident that was number 16. And so when you look at this one, you do see an increase in the number of items not responded to for the second half of June and going into early July. And we thought this kind of correlated with things that were going on at the residency at that time as well. So towards the end of June, our third-year residents are preparing for graduation. They're not having as many clinic shifts, so the other residents are taking additional shifts. And then similarly, July, when the new first years come in, they're they're doing introductory materials. So again, the remaining residents are taking additional shifts. So we figured increased shifts equals more inbox management and then correlates to likely more results that are pending.
Okay, I'll take over for the second half. So now we're looking at correlations based on the rotation the residents were on at the time. We see all the way at the left with the highest amount of results is geriatric rotation. Again, we're not completely sure why, but that's just a correlation we saw. Otherwise, inpatient rotations, pediatrics, and AMS for us as adult inpatient are much lower than expected. So let's see, let me look here again. So they're kind of towards the end, not the very last, but closer towards the end. And overall, what we've seen with others as well is the amount of results in people's inboxes seem to be higher than calls. But yeah, overall, these first few are clinic months. HFMC Peds means our clinic, where we prioritize seeing pediatric patients during that time. And then Derm PCMH is a clinic month, so a mix of kids and adults in that month. So those being on the higher end, it makes some sense to have more results in outpatient inbox filling up. Another correlation based on rotation, but again, this was minus our outlier, the other one included. So here, dermatology moved up in terms of the amount of results left in an inbox. Pediatrics and adult inpatient is still lower. There's likely some correlation based on which year, in residency, as some of these rotations are exclusive to only third years or, more so in first and second year. But overall, again, leaning towards the beginning are the more outpatient focused, and then towards the end is a little more inpatient. So kind of contrary to what we expected, we figured the workload is higher on an inpatient rotation, so the results that are there are likely to be kind of longer and take longer to be addressed, but it turned out maybe the quantity of results is higher, and that correlates more so with an increased amount not responded to. So now we got to a correlation based on the year in residency. So includes our outlier. We see first year, second year, very similar. Again, results is higher. Third year is much higher. This makes sense to us because we had the most clinic in our third year. It increases in amount as the years go. Not too much more at that, but let's compare it to minus our outlier. So now it becomes a lot more similar between the years. Still results is higher, and still a little increased in third year, but comparatively we could see how much the outlier affected it, as it's a lot more similar than we thought. So not a huge effect that year had. So now focusing, we were interested in the correlations to see if there's anything we could deduce or work backwards, but for the pre and post intervention, here we have a table of our results, so broken down by estimated calls, outlier included, outlier removed, result outlier included, outlier removed, just to give you a context of what we're looking at. So we had 28 people minus our outlier, 27 with the outlier. Our mean count here was the number of messages per resident. And as a reminder, that intervention was sharing information, kind of putting it top of mind. Hey, this is tied to your income and, potentially in the future, patient safety, things like that, the importance of inbox management in a timely manner. So mean count. So at first, including our outlier, there were about 1.7 calls without a response over 72 hours. Post, there were 3.3. So it actually increased by 1.9. And then rate ratio to, just as a reminder of these terms, comparison of estimated with no response per resident for pre versus post. So for estimated calls with no response, minus our outlier, 1.08 at first, 1.9 post. This was a difference of 1.8 rate ratio, P of 0.16. Then our results with the outlier, 5.5, you see they're higher as we've been seeing, and 7.2 after. So increased as well. P-value is also, like all of these, not statistically significant. So 0.59. And then results removing the outlier, 3 pre-intervention, 1.65 post. That was the only one that went down after the intervention. But overall, too, we did an intervention, we saw the effect, but none of it was statistically significant. So let's go into some of our conclusions about all this data. So as a whole, our residency does generally fall short of the 72-hour responses if we're, saying it's something we should always have done. We technically do not always have it done, but many are close to adherent. June and July had the highest number of results or calls consistent with our expectations about the workload being increased to second and third years, as first years are just on an intro block and don't have actual clinic requirements at that point. Clinic predominant rotations or higher working hours didn't necessarily show more inbox negligence, which is not what we expected. There was no clear correlation between the rotation and the inbox management. Makes us think there's a confounding variable or several going on. PGY year or PG year showed a significant increase by third year, which correlates with greater time in clinic. And there's variability between residents is likely a large confounding variable, how well the individual normally does. So if they are somebody who is usually on top of their inbox and holds themselves to the 72-hour, likely that's the biggest contributor, we believed. And then the people that don't or more lax about it are likely just generally more lax about it. So about our intervention in particular, we can't say that it had a meaningful difference on how well people managed their inbox. Potentially, the information was only skimmed or just skipped entirely. We didn't necessarily track if it was viewed or confirm that. Clearly, this information on the importance was not the root cause of why people don't manage their inbox. So at least that was some useful information to get out of it. And then again, our suspicion is that is an individual difference with personal reasons, whether it's somebody who is more inclined to kind of being on top of an inbox or not, probably has the biggest contribution. So our limitations and confounding variables, which we talked a little bit about. One, though, was our limited ability to view people's inboxes. One resident never shared it, so we had to exclude them. We viewed the inbox just at one point in time. There was no knowledge of the total calls that a resident had and had already responded to, so we can't speak on the proportion that were responded to or not. We had a small sample size, just 27 people, just one site of our residency. There's also the variable of us covering each other's inbox when somebody was on vacation. We didn't necessarily check for that or confirm that. We just randomized it to try to see, try to keep things as even as possible, but who knows what effect that had on the results. Other things that we just kind of postulate in life, differences in commute time, having children, personal life stresses, keeping items in inbox as a reminder potentially, all things that could affect your ability to be on top of your inbox.
You have 1 minute remaining.
Okay, this is really our last slide. So future work, extend our data collection to other parts of the inbox, portal messages, faxed items. Access the data Epic generates on overall trends of your management. Include a larger sample size with more than one site. And then there ultimately should be more research in the foundational causes of why an inbox is difficult to maintain. Possibly there's financial or performance impacts are more successful in other clinics and things like that. And then in residency, above strategies are not as useful as when it is really tied to our pay. That's a much larger motivator, we would think. That's the last slide. These are just some acknowledgements to our attendings and our residency that helped us, and Chase from Midwestern helped us with the data. Thank you.
And thank you both. As I mentioned, your faculty reviewers are Dr. Langdon and Dr. Collins. It looks like Dr. Collins has put a question for you in the chat.
Oh, sorry.
Thanking you first for your presentation. It's incredibly relevant to outpatient primary care. I'd love to hear your insights on 2 points. Here we go. What do you think were the underlying factors contributing to the outlier? And additionally, what strategies do you suggest for maintaining resident engagement with the in-basket, especially since your reminders did not change results?
Yeah, okay. So to be honest, since we know all these people too, I think the outlier is somebody that historically struggles with keeping up with it. So I think they're just, as a person, less kind of internally motivated to keep on top of it, and probably more of just like a personal. In terms of like specific things, otherwise, I can't necessarily pinpoint. And then you said what would be a greater motivator for residents. We always kind of talk about, or at least I'm one of the chiefs, so we talk about like, how do we want to manage residents or try to encourage them to do something that rewards tend to work a lot better than punishments, even like, just psychology, basic psychology says so. So having some sort of probably like less work would be nice, right? If you do a little extra work on your inbox, potentially you get a shift swapped, or, when in doubt, you don't have to take this call, so it goes to somebody, somebody else for some reason. Did you have other ideas?
No, I think that's a good one. I think kind of what we were saying with the motivation that sometimes you see in the work field, I think at least even talking to some residents, like off chance, it sounds like that is something that keeps a lot of people motivated, and that for sure does that. So I don't know if there's a way, again, residencies are limited with certain finances and how they can spend it on residents, but if there's some way, even with like wellness or putting more money towards that, or I don't know, it'd be a matter of, I think, some of the logistics within the residency program, but that could be another motivator too, I could see.
Okay. And one follow-up question, did you survey the residents to identify what they felt is a challenge for managing the inbox?
We didn't end up. We wanted to start with gathering the overall information. Where are we now? And yeah, just kind of focus it more narrow. But yeah, that's definitely a next step, is what would have helped you guys.
Okay. And then one final question, if you think the lack of impact by your intervention was the method, using email, or the content of the message. And he apologizes if there was other ways that was delivered.
Oh, no worries. Okay.
It's the what? Sorry, can you repeat that one more time?
If it was like the fact that it was email or a message.
Oh,
WhatsApp.
Right.
Mm-hmm.
I wouldn't say. I think the intervention, at least, I would think the WhatsApp message, especially, I think that's one that people are able to see, and definitely people make note of other things that go on there pretty frequently. So, in terms of the message being delivered to people, I don't think that was an issue. Maybe the email, more or less.
Mm-hmm.
I think, like Kelsey was saying earlier, more so whether or not that truly made an impact, and like she was kind of mentioning earlier, I think the like, internal motivation and like the external, factors that could be motivating people is more so what was making more of a difference on whether we saw an impact. And at least that's what our opinion felt like at that time.
Yeah, more future looking as well. One day it will affect your pay rather than right now it will affect your pay.
Understood. Well, I'd like to thank both of you for your presentation. And we will call up to the plate now Dr. Brittany Moat, and I'm just letting one more reviewer in. So you can, Dr. Moat, if you'd like to share your screen, we'll wait for your slides to pop up. Dr. Brittany Moat is also with the UChicago Advent Hinsdale Family Medicine Residency Program. Let's see if we can see her slides. And just to give a heads up for our two reviewers for this presentation will be Drs. Langdon and Dr. Baran Al-Hashimi has joined us. So two more overworked ER docs ready to stand by and watch your presentation. And then they will also provide questions after you finish. So Dr. Moat, if we can see your slides and see you, we'll get ready for the next presentation. Okay, we'll just need your first slide. We've just got that you are sharing your screen, but we don't. Oh, there you come. All right. Thank you so much. We can see your slides, and we need to make sure we can see and hear you. We're still not hearing you or seeing you. Got your slides, but we do not see or hear you at this time. check your microphone, make sure it's not muted, or check your, if you open up your audio settings, make sure that you have your correct microphone selected. And same with your camera, make sure that your computer camera is also selected. We still are not hearing or seeing you. Oh, there, I can see you now.
Hello.
There you are. Okay.
you hear
Hi.
me? Okay.
Yes, now we're good. Take a deep breath. The clock, you'll have 15 minutes. The clock will begin when you do, and then we'll have some questions for you. Good luck.
All right. I'm so bad at technology. This was okay. All right. So my presentation on my research this year was about improving the medicine clinic. So disclosures, there's no potential conflicts of interest, or I have any financial interest or relationships to disclose. Just briefly, the agenda today. So my PowerPoint will go over my introduction, my quality, the objective, the intervention, my methods, the data analysis, and then obviously the conclusion and discussion. So.
Dr. Moon, it appears your internet connection is not stable. You've dropped out quite a bit. Let's see if we can make sure your Wi-Fi signal is strong.
Okay. All right. So I'm not sure exactly if everything cut off, but just brief introduction wise, skin cancer is the most common type of cancer in the United States. It's estimated at 1 out of 5 Americans will develop skin cancer. Most are curable if caught and treated early. But why is this important to family medicine? So skin conditions and lesions are up to 36% of family medicine visits. And we usually are the first point of contact for most people. So the ability to identify and properly address and treat these lesions is an integral part of patient care. And ultimately, effective dermatologic care can improve early cancer detection and education to patients in general. So my quality improvement project, it was a pre-post intervention design to compare dermatologic procedure rates 6 months before and after an education dermatology presentation to family medicine residents. The confounding variables that were accounted for were the numbers. So we have a dermatology clinic that we have about every 4 months. So I made sure that that was the same number of derm clinics was before and after the presentation that I gave. And then also procedural labs that we have. So I just made sure that those were equal as well before and after this presentation. All right, so the interventions. So this was, I gave a 60-minute educational session that was delivered in May of last year. It included educational materials that were handed out afterwards, and then also procedural resources and demonstrations that were done during the presentation as well. So it covered identification and management of common dermatologic conditions that are seen in family medicine, and then also the indications and techniques and safety considerations for common procedures such as shave biopsies, punch biopsies, excisional biopsies. And then we did, we went over proper billing codes because that was ultimately how I was going to collect the data. Right, so for the data collection, that was collected from our EMR records from the Hinsdale Family Medicine Center. It was 6 months prior to and after the educational session. And those encounters included procedures that had shave biopsies, punch biopsies, skin excisions, cryotherapy. And then I also did a separate kind of review of just CPT codes for the dermatologic CPT codes and lesions and conditions that we discussed in the session as well. Okay, so for the results, a total of 298 patient visits were reviewed that included those dermatologic CPT codes that were discussed. And it was found that actually the same number, around 149, were identified before and after the presentation. And that was just a coincidence that it was the exact same. However, the number of procedures varied. So before the intervention, there was about 3.4% of the visits had a procedure. And then after the intervention, about 8.7% had a procedure. This represented a 156% increase in dermatologic procedures following the educational session, and that was found to be statistically significant. So the conclusion is that the educational dermatology presentation provided to his family medicine residents was associated with a significant rise in the number of dermatologic procedures and treatments performed in the clinic, suggesting improved confidence or awareness among providers in identifying and managing dermatologic conditions. And as a qualitative improvement initiative, these findings highlight the value of targeted educational interventions and expanding procedural skills and improving patient access to dermatologic care. Future steps would include probably reinforcing the dermatology education through periodic refreshers, workshops, or continued tracking of procedure rates to just assess the sustainability. All right, just going over some of the limitations. So obviously this project was only conducted in a single residency program, which may limit the ability to apply it to other training settings and populations. While we attempted to confront the confounding factors, such as the derm clinics and the procedure labs, other factors such as like the season, so it being in winter, spring versus summer, and skin conditions, sometimes that affects what we see. And then changes in clinic scheduling also plays a factor. And then after the presentation, if there was an increased faculty encouragement, may have also contributed to the increase in procedures that we're seeing. Additionally, the project relied on documentation of procedures in the EMR, which is subject to variability in the potential of underreporting or incorrect billing that was collected. And finally, this project did lack a randomized control. But despite these limitations, the findings still suggested that targeted educational interventions can be an effective strategy to enhance procedural exposure and resident confidence. So just to key takeaways, dermatology procedures increased significantly after the educational presentation. There's targeted provider education has effectively improved procedural confidence and the utilization in our residency program at least. And quality improvement interventions like this do have the potential to enhance in-clinic dermatology care. And the next steps is to implement periodic dermatology workshops, continue monitoring procedure rates to ensure sustained improvement, and then also making sure that what we're doing procedures on are, obviously indicated and implemented in a safe way for patient safety. So just acknowledgements. I'd like to thank my supervisors that helped me with this. Marianne Harrelson, who helped me in my data collection, and also my Hinsdale family medicine residents for their support and participation. Through my references, and thank you.
Thank you very much, Dr. Moat. Is it Moat? I'm just sure.
Yeah, it's Moat. Yeah, that's correct.
Okay. So Dr. Lang did put his question in the chat. First, thanking you for your presentation, then asking if did the intervention include hands-on practice of the procedures? I'm glad you mentioned the seasonality differences between the pre and post interventions. Did you compare it to prior years to see if the change could be explained partially by seasonality?
Yes, it's a good question. So yes, we did do hands-on practice of the procedures during the presentation that I gave. I actually also included microscopy review with some handheld microscopes that were magnifying tools that were made available to residents too, so they could get used to that. And then we also have procedure labs that were sprinkled throughout the year. So I just made sure that they were equal prior to and post, just that went over derm procedures and things like that as well. And then I did not compare the results to prior years. Unfortunately, I did go through all of almost 300 of those visits by hand. So just to make sure that they had the correct CBT code and the billing and what was actually done and what was, the biopsy came back as and stuff like that. So I did not necessarily, due to time constraints, but that is a good thing to potentially look over long term, what if it's explained seasonality or, what the comparison is.
Great. Thank you. I'll wait to see if Dr. Al-Hashimi has any questions. You can put them in the chat or you can unmute yourself and ask verbally. Oh, no questions, he says. All right. Well, with that, then, Dr. Moat, you are good to go. Thank you so much for your presentation. And then our next presenter, if Dr. John can get his slides up and ready and share, and then we'll get to our third presentation of this block. All right, Dr. John, you may need to unmute yourself. I think your camera's on, but I don't think your microphone's been activated.
Yeah, can you hear me?
Yep, there you are. Hello.
Hello.
And then share your screen when you're ready.
Yep.
And while you're doing that, I'd like to make sure that Drs. Al-Hashimi and Collins are on deck to review your presentation. While we're waiting on your slides, I'm going to introduce Dr. Patrick John, also from the Advent Health Hinsdale Family Medicine Residency Program, where research is abundant. His completed project is now up on deck. Just a reminder, you will have 15 minutes, and then our two doctors, Al-Hashimi and Collins, will have some questions for you at the end. The clock will begin when you do, and then when you hit 2 minutes left, I'll pop it in the chat and give a quick 2-minute warning if I can sneak it in without interrupting you. And then the floor is yours if you have any questions. Otherwise, I will wish you luck, and the clock will begin when you do.
Awesome, thank you. Can you see my screen right now?
Yes, we can.
Cool. All right. So, so my project was improving discussion follow-up of obesity at Hinsdale Family Medicine Center. Again, for disclosure, no actual potential conflicts of interest in relation to this program, no financial interest relationships to disclose as well. So to introduce, per a lot of different data that I went through, per the CDC, obesity prevalence in the US in 2021 was about 42%, and more than 35% of men, 40% of women in the United States are obese. As a lot of us know, it's closely associated with the development of a lot of different things, including coronary heart disease, type 2 diabetes, various types of cancer, gallstones, and disability, and especially linked with increased risk for death, particularly among the age group of 65 years and below. And what we have seen is that this age group, particularly 18 to 44 years old, has been shown to have the lowest prevalence of serious comorbidities of obesity, namely diabetes and heart disease. And the USPSTF recommends that clinicians offer or refer adults with a BMI of 30, so obese, to intensive multi-competent behavioral interventions. However, despite the importance of obesity management, less than 50% of adults meeting this criteria for either overweight or obesity received weight loss counseling from 2011 to 2018. So my project for our clinic specifically was trying to improve the confidence and regularity with which healthcare providers at our clinic discuss obesity with this particular age group of 18 to 44 to hopefully limit the amount of one, obesity there is, but their risk for having a lot of those different conditions, diabetes, heart disease, things like that in the future, and seeing if there's any relationship between a presentation of obesity and whether or not that increased the regularity with which the doctors in our clinic talked about it. So again, this intervention was a presentation that I gave on the 4th of March last year. It was reviewing again some of the stuff I went over: prevalence, associated adverse health events, management strategies, going over some EPIC SMART phases that I created to assist in obesity discussion and documentation. And then also reviewing the recommended follow-up timeline for obesity, which Dr. Bachhold in our clinic had come up with, going over what's an appropriate time for patients to follow up on based on the different conditions that they may have. So the methods was reaching out to the clinical data person in our clinic to run a report of patients aged 8 to 44 with that BMI seen in our clinic from that's July of the previous year to October of last year, using these filters to filter with BMI, obesity, or weight to determine which visits actually the providers talked about those things. And then the data points were encounters with one of the above diagnoses, documented discussion topics, which we'll go over. And then out of curiosity, I wanted to see if there's any difference between the providers, so between the PGY 1s to 3s and even the faculty. And then that data was split into 8 months before the intervention, which was the lecture, and then after the intervention. And so the first thing I was able to see was that the obesity visits did increase from before the intervention to after. It was about 100 and I think it was 20 or 18, I think, and before after and before it was around like 50 to 60. These were the topics that were specifically discussed. So diet, exercise were obviously the mainstay initial things that we like to talk about for our obese patients. So the lifestyle modifications. Then we got into medications, nutrition referrals, and then the follow-up visits, whether or not we instructed patients to follow up for the obesity, bariatric surgery, and then I included a category of none on there to determine whether people actually were talking about the obesity or not. Or talking about specific interventions, if you will, rather than just putting it on there as a diagnosis and then not really talking about it during the visit. So as expected, diet and exercise was the most, but we see an increase in almost every category except for surgery before and after the intervention. And then this is just another breakdown of that same chart, kind of showing that there was an increase in everything except for the surgery. Some more than others before and after the intervention. This was just another chart that I created, kind of pulling all of the topics that were discussed before and after the intervention to generally see what's the topics that people seem to be more comfortable talking about and or more commonly talking about. And that obviously, again, was the diet and exercise. Medication was actually pretty similar to the exercise, which is good. We've added a decent amount of talks on medications for obesity throughout the last couple of years or so in our residency. So that probably contributes to that as well. And the follow-up percentage was okay, but probably not up to par with where it should be. So the results, the main I guess study that we looked at was the rate ratio. That's the main important thing between before and after the visit. But I went ahead and did a chi-square analysis and a t-test for the overall topics discussed. But the rate ratio was with a p-value of less than 0.001, so it was statistically significant. However, the chi-square analysis between the different topics discussed, that was not as statistically significant as the overall increase in talking about obesity in the clinic. This was the chart that I created for the comparison of obesity visits between the providers And as we see, the PGY3s ended up talking a lot more about it, but that probably contributes a lot to just us having a larger patient volume more than anything. But there was an increase in our providers talking about obesity before and after the intervention. But as this slide shows, with the chi-score analysis, it wasn't as statistically significant, which is not that big of a deal. But I think it's interesting that we were able to see a lot more providers talk about obesity in the clinic. So just a review of those results again. The total obesity-related visits did increase from 63 to 110. Those are the numbers, which was a 75% increase. The increases were observed across all residency levels and faculty providers, although that was not statistically significant. The documented obesity counseling, weight management interventions increased from 86 to 151 total times that we talked about those different things. And then the rate at which that increase, the rate ratio was statistically significant before and after the intervention. So again, conclusions from that, there's a plausible correlation between periodic education for healthcare providers on obesity management, the frequency at which those discussions and visits for obesity occur in the outpatient setting. And then these are just some opportunities for future research. One thing would be correlation between the frequency of obesity discussions and then perhaps improvement in the BMI itself in those obese patients to really see if that's actually making a difference in our patients. And then the other thing would be periodic or regular surveys for residents to evaluate, again, strengths, weaknesses, barriers to discussing obesity with the patients in our clinic. And then the final thing would be how using the specific smart phrases or note templates could affect the ability to have meaningful discussions on obesity in the clinic setting, especially as the encounter times get shorter and shorter from the PGY1 year to the PGY3, going from 60-minute visits to 20-minute visits. And then for a lot of providers, after they graduate, they end up potentially doing even 15-minute visits. So really seeing if that makes a difference in how well we're able to talk about that with our patients. These were my references, and that is it.
All right, thank you so much, Dr. John. As a reminder, Dr. ACCME and Dr. Collins, either one of you can put your question in the chat, which Dr. Collins has just done. Thanking you for your presentation. Did you consider examining pediatric obesity as well? Given that it is a major risk factor for adult obesity, I'm curious if earlier intervention in that population might yield even greater benefits.
Yeah, I actually did end up talking about this with the two other doctors that I was working with for the project, and we just decided that we were going to focus on the adult population. But that is also another thing I could have easily included in that future research opportunities to discuss the pediatric, because we definitely do see a lot of that in our clinic, and that's something that we have talked about in our lectures and stuff. How we have to remind ourselves that if kids are coming in for like a well child visit, it's very easy to just see that obesity like red flag on the epic chart, but not actually discuss it with the patients or actually have them follow up for it. So yeah, definitely an area that we could investigate more.
Thank you for that. I'm going to hang tight for another minute or two to see if Dr. ACCME has also added a question. She thanks you for your presentation and asks if you accounted for any possible external factors that could have also influenced the data.
Mm-hmm. So one of the things that made it, I guess, a little interesting is, on one hand, I don't think everybody necessarily was present for that lecture that I gave, so that could have influenced things on one hand. The other thing was, it was around a time where the graduating third years were preparing for boards and everything. They're about to graduate. So that those PGY1 to PGY3, that was including data from the previous years and the current years at the time. So that could have influenced it. And obviously, the other thing that could have affected things is patients on their own, like coming to our clinic to follow up. That could have skewed the data to be less potentially. We could do all we can to have them follow up and ask them to follow up. But whether or not they actually make it to the clinic for a variety of reasons could have affected the actual numbers that I got. So those are just a few off the top of my head I can think of.
Okay, I'll stand by one to see if they have any follow-up questions. All right, I think you might be good to go. So thank you so much, Dr. John. And I actually just saw our next presenter is hopping onto the Zoom. So I'm going to give her a minute to join on board and make sure that we can see and hear her. As a heads up, we have one final presentation left in this block. And I will need Dr. Collins and Dr. Langdon to hang out for this one. So with that being said, Dr. Katroth, if you are seeing and hearing us, let's make sure we can see and hear you. If you don't mind going 10 minutes ahead of schedule, you do have the right to hold off until your 12:20 presentation time. But if you'd like to start a little earlier, we can accommodate that as well.
Sure, I'm ready. We can do that.
Well, hello. Good. We can see you. We can hear you. I'll give you a minute to pull up your presentation and share your screen. And make sure I can pronounce it. Is it Katroth?
Yeah.
And first name Sumalata?
Sumalata, yeah.
Sumalata. Okay, well, there you go. So I'd like to welcome then Dr. Sumalata Katros. She's also with the Mount Sinai Jackson Park Hospital Family Medicine Residency Program. Her presentation is a completed project, and your faculty reviewers will be Dr. Heather Collins and Dr. Frank Landon, not their real names. Just a reminder, once you begin presenting, you'll have 15 minutes. If you get to 2 minutes remaining, I'll give you a quick heads up in the chat and a quick verbal 2-minute warning. At the end of your presentation, Dr. Collins and Dr. Langdon will have some questions for you that they'll either put into the chat or unmute themselves and ask verbally. If you have any questions, now's the time to ask.
Sure, no, okay.
You're okay? Okay, well then good luck to you, and the clock will begin when you do. Thanks for being here.
Sure, okay. All right, I am ready. Should I start?
Yes, you may. Go ahead.
All right. Good afternoon, everyone. I am Dr. Ketroth. I am doing my PGY3 residency in Mount Sinai Jackson Park Family Medicine Program. Today, I'm going to present on multi-level barriers to an adult vaccination in an underserved community clinic. So whenever we walk into, patient's room, when we ask them, hey, do you want to vaccinate today? Most of the patients just say no. So I thought we have to understand what are the barriers. Why do they say no to the vaccines? Do they even know what kind of vaccines they're supposed to take according to, according to their chronic disease condition, maybe, or according to their age? So I thought, okay, I think this could be the better thing if I try to assess what are the barriers. So my initial study was to understand the barriers. So I'm going to give a brief background about it. These are the trends according to 2018 to 2023. Influenza vaccine, there is like 40 to 50% uptake, but still it's suboptimal. And then even the shingles, there is increased marked improvement, but it's not enough. It is suboptimal, even coming with pneumococcal, Tdap, COVID-19. But surprisingly, COVID-19 had high initial uptake, but declining boosters. So why, despite the clear recommendations for adult immunization, many eligible patients remain unvaccinated due to modifiable barriers at the patient, provider, and system levels? So we need to better understand these barriers so that, we can improve patient awareness, acceptance, and uptake of adult vaccines. As a family medicine, it is very important for us to understand and fill the gap. According to the previous studies, the most common barriers to vaccination is interpersonal. It is related to patient knowledge and attitudes. And then comes the other underlying systemic and, provider level barriers like maybe like coverage, reimbursement, and then workflow and data reporting. Related to patient-related barriers, maybe their lack of awareness about recommended vaccines, fear of side effects, and vaccine misconceptions, low perceived importance of immunization. Coming to provider-related barriers, there is limited time for counseling during visits because they are very busy addressing the chronic conditions or maybe, some other important medical conditions. So they do not have enough time because of time constraints. They do not find enough time to counsel. And then inconsistent vaccine recommendation practices and missed opportunities. With regards to system-related barriers, maybe they have difficulty accessing vaccination services. Not every clinic has all vaccines, insurance or cost concerns, and lack of reminder or follow-up systems. So these were according to the previous studies. So my study objective is to assess patient knowledge. The primary objective was to assess patient knowledge, attitudes, and perceived barriers toward adult vaccines. And then secondary objective, once we understood what are the barriers, why patients say no to vaccinations, we also try to implement some educational intervention to make sure the patient understand what kind of vaccines they need. And simultaneously, we also evaluated residents to look at the challenges they are facing while providing vaccines to the patients. So we have conducted a cross-sectional study at Jackson Park Family Medicine Clinic, and then we assessed around like 80 adult patients who visited the clinic, and it was an anonymous paper-based survey. And we have offered it during the check-in and when the patients are waiting in the waiting room, and it's a voluntary participation. The questionnaire demands 5 important sections. They include age, sex, education, knowledge and awareness, vaccine history, how long ago was their last vaccines, and their attitudes and perceived barriers, what are the barriers, and if they are willing to vaccinate in the future. So these were the 5 components we assessed. And then we have assessed if they are aware of vaccines like flu, COVID-19, Tdap, shingles, and PCV20. And like I mentioned, their prior vaccination status and the reasons for not getting vaccinated, and whether providers are discussing the vaccines or not. All of these were included in the questionnaire. Some of the barriers we have assessed was some of the patients, they think they do not need vaccine is needed, fear of side effects, they're not recommended by the doctor, or maybe cost issues, time constraints, or personal or social beliefs. So according to the results in the phase 1, most of our patients were 35% were aging between 45 to 59, and 27.5 were between 30 to 44, and among them 57.5 are females, and among them 32.5% were high school graduates. So here is the result. 95% people were aware of COVID-19, 92% people were aware of influenza vaccine, but surprisingly, only 65%, 50 to 65% people were aware of other vaccines like Tdap and shingles and PCV20. And the uptake, even though the awareness among COVID-19 and influenza was high, the uptake was only to 60 to 70%, and the least uptake was 25% in PCV20. So, and then among these patients, 65% have reported that they need more information about vaccine that would help them feel comfortable about getting vaccinated. So this finding suggests that gaps in knowledge and limited awareness are major barriers to adult immunization within this population. And in contrast, factors like provider recommendation, access to services, and cost were less selected frequently. So this indicates that in this group, improving patient education and addressing misconception about the vaccines may have a greater impact on vaccination uptake rather than focusing solely on structural or systemic level barriers. And then simultaneously, we have assessed the residents also to better understand what are the challenges they are facing while giving vaccination. So some of the components we have assessed were like how frequently they get, they get to consult patients about vaccination, how confident they are, and what are the perceived barriers, what are the specific challenges, and then we also ask them if there are any improvement strategies which would help vaccination uptake. And among the 15 residents, 53.3 almost always they counsel patients. 46.7 they often counsel patients, and among them very confident are 53.3%, and 100% all of them have picked patient refusal or hesitancy as the main barrier in refusing in providing vaccinations, and then 53% in limited time and lack of patient knowledge. Among them, COVID-19 was the vaccine they were able to they had most challenging to discuss or administer, 73.3%, and shingles 33.3%. Some of the strategies they said was if we provide patient education materials, 93.9%, that is 14 residents have said if we provide patient education materials, that might improve adult vaccination rates. And some of them said EMR reminders and dedicated staff support too. And additional resident level findings were like frequent new patient encounters, frequent walk-in visits, and limited continuity of care, especially in underserved community clinic, and lack of long-term patient follow-up. So we took their inputs and we have implemented some educational handouts to the patients. We gave them, we educated them about the particular specific kind of vaccines they are supposed to take. And we have assessed them after education to better understand if they have got all the information they needed. And 95% they have reported improved understanding of vaccines, like they have understood what kind of vaccines they're supposed to take, including Tdap, shingles, PCV20. And 90% were likely to receive recommended vaccines within 6 months. All the patients have reported improved clarity of information and better resolution of concerns. So, in brief, awareness was highest in COVID-19, which was 95%, and followed by influenza, 92%, but lower for Tdap, which is 65%, and then followed by shingles and PCV20. So this suggests that strong recognition of recently emphasized vaccines, while routine adult vaccines remain under-recognized. And among them, the most common barrier is 45% said perceived lack of necessity, and fear of side effects 30%. But among them, 65% were interested and they requested more vaccine related information. So this highlights major educational gap. Like we already mentioned before, 53.8% residents, they routinely discuss vaccines, and the main key barrier was 100% patient hesitancy. So the conclusion is adult vaccination gaps are mainly driven by low awareness, perceived lack of necessity, and inadequate provider counseling rather than the cost. So patient education significantly improves understanding and short-term willingness to vaccinate. However, provider workflow limitations, time constraints, and lack of continuity in residency clinics reduce consistent vaccine counseling. And some of the system level barriers include like frequent new patients, limited follow-up. They further impact preventive care delivery. So now we have decided we're going to do a phase 3 study. This will be done by some of our juniors. They will evaluate actual vaccine uptake after post-intervention to, we're going to educate patients in every visit, and then we're going to track how many patients receive recommended vaccines after counseling. So this will help determine the long-term impact of education on real immunization behavior and guide future quality improvement efforts. So we're going to integrate vaccine education in future into routine visits, strengthen provider prompts and reminder systems. We're going to also improve continuity and focus on preventive care in residency clinics. These are my references. Thank you.
And thank you as well, Dr. Catros, for your presentation. I'm going to pull up Dr. Langdon offered the first question in the chat. He asked, on your surveys to patients, was there a free response for them to indicate why they were hesitant for vaccines, or was it a checkbox? I wonder how much of an impact the changing recommendations from the HHS has affected patient vaccination rates.
So most of them, they said they do not know what kind of vaccines other than influenza and COVID-19. They were not even aware that something like Tdap, pneumococcal shingles vaccine, they were supposed to, get them according to the chronic diseases, be according to the ages. So they are not aware of what kind of vaccines they need to take.
Okay, and Dr. Collins would like to ask, well, first she thanks you for your presentation, then asks, how did you choose the vaccines that you focused on? Did you consider childhood vaccines, HPV, et cetera, or if those would have different barriers for those vaccines?
We have just selected these 5 vaccines, like adult immunization vaccines. We did not take any childhood vaccines. Okay. So our ages were 18 and above, so we just focused on those 5 vaccines.
Okay. And in your in your questionnaire to patients, did you ask where they get their education or where they wanted to get education from if they cited a lack of knowledge on vaccines?
Yeah, they just mentioned like we have just had a limited questionnaire, and among them they mentioned like lack of education. So we have decided when they come to us in a routine, routine visits, we would educate them about vaccines in each visit to make them better understand about the vaccine, importance of vaccines.
Wonderful. I will leave it open in case Dr. Collins or Dr. Langdon has any other questions on this particular project. Okay, I think you might be ready to go. So I will, you can stop sharing your screen if you'd like. I will share mine and just do a couple of minutes of wrap up since this is our final presentation of this block. Just a reminder, we are still in the award season for the IAFP, where you can submit IAFP members for any of these awards, and it's easy to find on our website on IAFP.com. And then also, I want to thank all three of our reviewers, Dr. Langdon, Dr. Collins, and Dr. Elashimi. Please make sure you submit your scores using the SurveyMonkey. Make sure you get that done by end of day today. For those of you who are submitting for CME Credit, I put the link in the chat. And I also put the link for the Google reviews. Everyone on today's webinar is welcome to provide their feedback. We appreciate it very much. The scores and comments from all of our reviewers will be compiled by me and hopefully able to send directly to each lead presenter by end of day tomorrow. And just so you know what's at stake, a gift card from Amazon will be given to the highest scoring presenter in the completed and in progress categories. We thank HACU Healthcare Associates Credit Union for providing the gift cards and for their support. That does it for this block. Believe it or not, nobody asked to present between 2 and 4 p.m. So we're going to have a nice long break, and we will be back at 4:20 p.m. with the final 4 presentations of the day. Thanks everyone for being here. Hello and welcome to the 4th and actually 3rd and final block of our 14th annual Scholarly Works Virtual Summit. We were planning on 4 presentations for this final block. I think there may only be 3. We have one presenter who I could not nail down a confirmation, so there may only be 3. But we welcome everyone back and thank you for everyone who's been with us throughout the day. Just a reminder, we hope this program reflects our commitment to diversity, equity, inclusion in all of its forms. We hope today's activity upholds and lives up to that commitment. We did the faculty disclosure and CME language earlier today, but all of our presenters disclosed no relevant financial conflicts of interest, and that would be Dr. Kim, Dr. Batalev, and Dr. Petwari, and myself, Ginny Flynn. Today's full webinar is eligible for up to 3.5 AMA PRA Category 1 credits if you watch all of the presentations either live or on the recording, which will be added to our YouTube channel at a later date. In order to claim your post-test CME credit, there's different instructions for today's live attendees and our online enduring credit participants. I will have the chat linked to today's CME credit claim form for our live attendees. I'll post that in the chat a couple times during this block. We have a couple of fun events ahead. We're going to the White Sox game on Sunday and the Chicago Sky basketball game in September. Both of these events are easily found on our IAFP.com website under events. And we have a live auction, silent auction going for tickets to see the Savannah Bananas at Wrigley on July 24th. Bidding is open till July 12th. You can use this QR code to see more and place your bets. And then finally, don't forget Family Medicine Midwest in September. Registration is now open and the deadline to register is August 30th. It's in September. It's just across the border in Indianapolis. And we'll be holding a free CME on the new end-of-life options for the Terminally Ill Patients Act. That's a free CME program, June 18th online, and it's at noon. And all these again are on our IFP.com website under events. Don't forget, we have our IFP awards that are up for nominees, and that deadline is August 1st, easily found on IFP.com under 4 members. So how does this work? Each presenter will have their slides ready to go on their desktop and have 15 minutes to present. You'll get a 2-minute warning when you get to that point. We have 2 volunteer faculty reviewers assigned to each of our sessions. They have fake names, and what they'll do is either put their questions for you in the chat or unmute and ask them verbally once you've concluded your slides. And what's at stake? The top scoring presentation in each category will receive an Amazon gift card, which was provided to us from Healthcare Associates Credit Union, so we thank them for their support. With that said, let's go on to the presentations. I'm going to stop sharing my screen so that Dr. Petwari can pull his up. And introducing for this first presentation of this block is Dr. Nirav Petwari from the University of Illinois College of Medicine at Peoria Family Medicine Residency Program. He's doing a completed project and assigned to review and ask questions for you are Dr. Yolanda Garcia and Dr. Michael Robbie Rabinovich. So once we can see your slides, we'll make sure we can see and hear you, and then the clock will begin when you do.
It's nice to meet you all. Unfortunately, the camera's still not working, and the troubleshooter says that it crashed. So I have to go without a camera for now, but I can get the slides up at least.
We're still waiting to see your slides as well, and you might need to speak up just a hair.
Okay. Can you hear me better now?
Yes, I can. We can see your slides.
Perfect. Here, let me get started with that then. All right. So, welcome, everyone. My name is Nirav Petwari. I'm a PGY1 family medicine resident at the University of Illinois College of Medicine here in Peoria. My topic today is an interesting patient case and important learning takeaways for it. It is about the selection of a steroid for an epidural steroid injection in a patient with alpha-gal syndrome. So, the overall goals for this presentation for our learners are to define what alpha-gal syndrome is, understand how it can present, what different causative agents could be, and understand how to choose medications for alpha-gal syndrome patients. What we can do to identify different additives in ingredients in those medications, and how to explain initiating new medications in these patients, given the risk of reactions. So overall, what is alpha-gal syndrome? It's one of those things that you learn about very briefly in med school for about 5 minutes, and then think you'll never see again until you do. So it is an allergy to mammalian meat and mammalian-derived byproducts caused by this little guy here, the Texas lone star tick Amblyomma americanum, more common in the American Southwest and Southeast, is caused by an IgE antibody forming to galactose alpha-1,3 galactose. And with these allergies, compared to a typical allergic reaction, say to peanuts, these are often much more delayed, occurring 3 to 8 to, in some cases, 12 in some of the literature that I reviewed, hours after exposure to the allergen. Typically, the allergy tends to present more as GI symptoms, so nausea, emesis, bloating, gas, diarrhea, that kind of stuff. Less commonly, you will see them develop anaphylaxis. It can still, however, happen. And you can still get, some of the classic allergy findings, erythema, pruritic rash, that kind of stuff. Given the dissociation between onset of being introduced to the allergen and getting exposed to it, and the massive time delay in having a reaction to that allergen, it's pretty difficult to diagnose a condition and often goes under-recognized. So patients that have alpha-gal syndrome often have very significant impairments from that. A lot of products are derived from mammalian tissues, the obvious ones, food, beef, that kind of stuff, but also a lot of flavorings that we use, medications that we use, and even some of the preservatives within food and within medications. However, it's important to note that not all mammalian-derived products can't cause alpha-gal reactions, and different patients actually have different responses to the same exposure, and even within patients, they can react differently to the same exposure. Unlike other allergens that we can see, things like peanuts, soy, wheat, milk, manufacturers aren't required to report alpha-gal content in anything they make, food, medications, whatever it may be. And they aren't required to disclose changes to inactive ingredients within medications that could contain mammalian products. For example, here's some medications and devices documented to cause alpha-gal reactions as they contain some alpha-gal. Some of the important ones here are stuximab, infliximab, are monoclonal antibodies, heparin and enoxaparin. You need to be very careful with those. Bioprosthetic heart valves, especially those derived from porcine heart valves, those can cause very severe reactions in patients. And this is here demonstrating what we do have currently in terms of disclosing possible allergens or other harmful food additives. Of note on the full bottle of Coke here, you can see it contains phenylalanine and has warning for phenylketonuria. Whereas this allergen label here notes that, hey, it contains wheat, soy, egg, can contain tree nuts. And we've often seen labels in other facilities that say things like, hey, may contain traces of blah, 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 or made in a factory that also processes meat, peanuts, soy, etc. This is not a requirement for alpha-gal in any products, really, food products, medication products, preservatives, food colorings, what have you. So with that in mind, let's move on to the big case that we have today. It was a really fascinating one. It was a 61-year-old female, past medical history of alpha-gal syndrome. She was working on a project at home, got her foot stuck in a ladder, and then developed some pretty severe left leg pain as well as low back pain, notable for typical neuropathic type symptoms of burning pain radiating down her leg from the low back. Initially, she got workup including an x-ray that ruled out any kind of fracture or acute bony finding. She got managed with physical therapy as well as conservative medications like Tylenol and ibuprofen. However, unfortunately, she did fail management with those medications. None of them really covered her pain. So she got additional workup. Lumbar MRI was notable for left lateral disc extrusion to L4 and L5 with severe impingement of L5 nerve root. And it also showed very significant neuroforaminal stenosis at L5 and S1. Given that, the PCP and later on an orthopedic surgeon made a decision to trial acetaminophen, hydrocodone, amitriptyline, gabapentin, other agents like these to help kind of control these neuropathic pains that she's having. However, she unfortunately failed treatment with these. None of them really covered her pain. So she was referred to the interventional pain clinic that we have here in town to undergo an epidural steroid injection. However, that raised an important question and a really big problem. What steroids, if any, would be safe for the patient to receive? Per the chart review, she had never had any steroid injections in the past, and there was no history of her getting any kind of oral steroid either. So we weren't really sure what we could use for the patient that wouldn't cause an alpha-gal reaction. Because of this, we ended up making a consult to the hospital's pharmacy team, who made this wonderful little table here. This goes through the three main medications that we carry in the interventional pain clinic, the three main steroids, betamethasone, dexamethasone, and triamcinolone, as well as the preservatives included in each and potential mammalian compounds in each. Of note, for these three meds, there is a possible containment of polysorbate 80 within the triamcinolone. However, on reaching out to the producers of Teva Pharmaceuticals, they state that their medication does not contain any ingredients derived from animal or human origin. However, since it does still contain polysorbate 80, which is sometimes seen from mammals, we made the decision to hold off on triamcinolone trial injections with betamethasone and dexamethasone instead. So she underwent both of these injections. Betamethasone injection did not cause any alpha-gal syndrome reaction, thankfully, but didn't really have any relief of the patient's pain. With the dexamethasone injection, similarly, no alpha-gal reaction, thankfully, but only a mild decrease in her symptoms. Like it says there, avoid triamcinolone because we did not want to risk a potential reaction for her. So after she failed the management with the epidural steroid injections, She was referred to for an orthopedic eval for surgery and underwent a left L4, L5 hemilaminectomy and discectomy, which did have pretty substantial improvement in her pain. When I followed her up with her, she was doing much better. So, what are the main takeaways for this case? Key things to look at: alpha-gal syndrome is rare, often underdiagnosed, in part because it presents very oddly compared to traditional allergies. It does not have the same strength of correlation between exposure and time to reaction that a lot of standard allergies have. And that can make it really difficult to relate symptoms to an exposure. No one really thinks about the ham sandwich they ate for lunch 8 hours ago, causing some of the itching or GI issues that they're having now at 8 p.m. So as a result of this and the big concerns for reaction in alpha-gal syndrome patients, the medications and other products that they can receive are pretty limited. And different patients with alpha-gal syndrome can have different reactions to the same medication. Some may have no reaction at all. Others may have full-on anaphylaxis. And as there's no comprehensive list of products containing alpha-gal, it's important to reach out to manufacturers regarding the contents of medications that they have, especially as the manufacturing process varies very widely between companies in terms of what they include in their medications. Everyone always, of course, thinks of what the medication that's in the medication, but we never really think about the preservatives in the medication, stabilizing agents, what the capsule could be made of. These things are all possible triggers for an alpha-gal reaction that a lot of the times we don't really consider. There was a very interesting case report I read while doing the research for this that involved a patient with Hashimoto's disease and alpha-gal syndrome. Could not get any products with Synthroid in it, though, because they would always cause an alpha-gal reaction for her. They ended up having to go to a special capsule manufacturer that specifically made vegan capsules in order to avoid causing a reaction. Only then was she able to take levothyroxine. So now that we know we need to reach out to manufacturers, what are other things that we can do to look into alpha-gal content? Package inserts for medications that often get included with the box that comes in can be a helpful resource, as it does list other ingredients contained within the medications, creams, whatever you have. And in addition, we can reach out to manufacturers directly, which is what we did for the manufacturers for these 3 medications, in case the product package insert does not really describe alpha-gal content. With this, however, it's very hard to completely rule out the presence of alpha-gal in any certain medical product. So when you're talking to patients about initiating a new treatment, a new medication, swapping over to a new type of pill, new manufacturer, whichever it may be, it's really important to go through the risks and benefits of having alpha-gal exposure to them. So these are my main sources that I used. Are there any big questions for this?
Thank you so much, Dr. Patwari, for your presentation. And at this time, the floor is open for questions from Dr. Garcia or Dr. Rabinovich. Okay, Dr. Rabinovich has his question in the chat. First, he thanks you for your presentation. After having read up on this topic and taking care of the patient, how will this case impact your day-to-day practice in with the general patient population outside of just patients with alpha-gal syndrome?
Yeah, great question. So in terms of day-to-day practice, managing patients that don't have alpha-gal syndrome, the case raises a pretty important consideration of what else is in the medications that we prescribe to our patients. Like I said, we think about the medication that's in the pill, but we don't think what else the pill is made of. And that's important to consider for patients for various different reasons. For example, one thing that is often amyl-derived can be gelatin. And for patients that, for example, are Muslim and are unable to take any pork products, that's pork-derived. So the capsule that they get really work alongside their religion. So making adjustments to that based off of individual patient concerns, conditions, that kind of stuff. Looking into that to make sure that our patients have the best medication that works the best for them.
And Dr. Garcia would like to know how did the team monitor the patient after the injection of the steroids? Was there a protocol or plan for monitoring each one?
So after the patient got the injections, they did keep her overnight for observation. They kept a close eye on her, including her vitals, frequent checks by the nursing team in order to look in for any skin reaction, GI symptoms, and symptoms of anaphylaxis. All of that to make sure that the patient was otherwise doing well. Thankfully, she did.
Check and see if anyone else has any questions for you. We're going to take a question from Dr. Manning, another one of our reviewers. Rabinovich and Garcia will be providing your scores, but another faculty expert, Dr. Natalie Manning, is on board and has put a question in the chat for you. FYI, alpha-gal is becoming much more common on Martha's Vineyard, an island off of Cape Cod, and it is now reportable in Massachusetts Public Health. Fascinating. Restaurants throughout the whole island have an alpha-gal safe menu now. Informal estimate is 10% Lone Star tick aggressive positive in year-round residents on one end of the island. So apparently Martha's Vineyard is a tick haven.
Oh, did not know that. That was neat to know that.
I know. That's fascinating. I wonder if that's something that can be replicated. One other question for you. Were you able to take what you learned in this particular case and create either some sort of template or tool for your clinic, whether it's for, posting what you were able to determine about potential contraindications for alpha-gal or any other kind of condition where you might have to repeat these kind of extra steps to ensure patient safety? Did you create any kind of tool or template that could be replicable and used for any of your clinic colleagues?
I know, actually. That's something I've been working on. I did have a similar presentation here with the College of Medicine here, also going through this case, presenting it to other, to other members of the College of Medicine, some attending, some fellows, co-residents, our lovely medical students. But I haven't actually created a way to work that up in terms of steps to look into if you're concerned a patient is having reactions to products within a medication. Yeah.
And are you planning to submit for publication?
Yes, I am actually. It's currently submitted pending approval, fingers crossed. Submitted it to the journal Pain Medicine Case Reports. So fingers crossed, hoping for the best. They take a little bit to get back, but I'm hoping it'll be accepted. I felt pretty good about the write-up that I did for this. It was a really cool project. Yeah. No.
Well, wonderful to hear. And by all means, please let your academy know if it's accepted.
Yeah, will do. Thank you. Thank you.
Fantastic. Any other questions from the faculty on board? All right. And of course, Dr. Manning hopes you come to Family Medicine Midwest.
They don't accept case reports, they said.
Yeah. Well, even save it for another day. And then we don't have a presentation scheduled for 4:40. Nobody wanted that slot. So thank you, Dr. Pitwari, for your presentation. You can stop sharing your slides.
Okay. Sweet. Thank you very much.
Okay, and now we're back with our 520 presentation. And it's my privilege to introduce Drs. Jisoo Kim and Dr. Jennifer Munoz from the Loyola McNeil Family Medicine Residency Program. They're going to be presenting their completed project, and reviewing this presentation will be our two anonymous reviewers, Dr. Manning and Dr. Garcia. What will happen is you will have 15 minutes to present your slides. The clock will begin when you do, and then Drs. Manning and Garcia will be able to ask you questions at the end of your presentation. So I'm going to go ahead and put your presentation full screen. We can see you, we can hear you. So when you're ready, you'll have your 15 minutes, and good luck.
Thank you. So like you said, I'm Jennifer Munoz. I'm Jisoo Kim.
And we're third-year family medicine residents at the McNeil Family Medicine Center in Berwyn, Illinois. And we're going to be presenting our research project titled, Wait a Minute, Are We Addressing Pediatric Obesity?
Okay, so why are we doing this project on pediatric obesity? Well, first, obesity is prevalent. So 18.5% or 13.7 million children and adolescents in the US are obese. And this prevalence does vary by ethnicity, as you can see here, with CDC data showing that obesity is most prevalent in Hispanic children, 26.2%, and followed by non-Hispanic Black children, 24.8%.
You may need to drop a hint when you need another slide. And also you might want to speak up a little bit, please. I don't want to get ahead of you.
Okay.
Thank you.
Can we get the next slide? Yep.
All right. So obesity is also very expensive. In 2019, the estimated annual medical cost of obesity in the US was $1.3 billion. Next slide, please.
And thirdly, obesity is dangerous, as we probably all are aware. Obesity just by itself can put pressure on children's bones and joints, but they also present with numerous comorbidities, some of which are shown here. So they range from high cholesterol, hypertension, diabetes, sleep apnea, and these are diseases we think about typically with adults, but with pediatric population with obesity, these can be prevalent as well. And going on to the next slide.
All right. So how do we define obesity? So we go based on percentiles of BMI. So in children and adolescents, overweight is defined as BMI between 85th and 95th percentile. Obesity is considered above 95th percentile, and then severe obesity is BMI of greater than 120% of the 95th percentile.
So going on to the next slide. So how should we be treating obesity? So the best kind of guideline out there is the 2023 American Academy of Pediatrics Clinical Practice Guidelines. So there are a few grade A recommendations which are shown here, evaluating for specifically NAFLD with the elevated liver transaminitis and treating comorbidities with obesity concurrently. There are plenty of grade B and C recommendations, as you can see here, many of which have to do with, again, screening for comorbidities. So screening for diabetes, prediabetes, high cholesterol, evaluating for high blood pressure. And there actually are recommendations for weight loss pharmacotherapy and even bariatric surgery for pediatric populations over 12 and 13. So, and there are also recommendations to have kind of a more holistic approach to counseling these patients. So getting families involved. So going on to the next slide.
So early identification of obesity is very important because that's how we prevent chronic disease development. It also allows us to develop healthier lifestyle choices earlier on so that they can last on into adulthood. Studies also support that having close follow-up is very, very important. Can be with goal setting and keeping the patients accountable, giving appropriate referrals to therapists or the dietitian, where they can receive basic education on reading food labels and stuff like that. And also involving family members, including siblings and parents, because this not only improves BMI for the patient themselves, but also for the whole family. And it's just more sustainable in the long run when more people are kind of like being kept accountable. Next slide, please. So this is the clinical flow for assessing and evaluating pediatric obesity based on the 2023 AAP guidelines. So we want to start off with screening for obesity. And this is, we assess the BMI percentiles using age and sex-specific CDC growth charts. This is between the ages of 2 and 18. Once they screen positive, then we want to kind of communicate that diagnosis to the patient. And again, it's important to kind of ask for permission to talk about this because it can be a sensitive topic and using neutral words. So like this is an unhealthy weight, or you're gaining too much weight for your height or your age, stuff like that. And this also kind of helps build that patient-physician relationship and build that trust. And then after that, you want to obtain a comprehensive obesity-specific history, a past medical history, medication, family history, social determinants of health, review of systems, which in obese children can include like females having irregular periods, GERD symptoms, depression, knee pain, shortness of breath when exercising, etc. Then after that, you want to identify risk factors and protective factors related to healthy behavior. So just an example of a few risk factors to look out for is like excessive screen time, or maybe eating a lot of processed foods at home. Then you want to kind of conduct your focused physical exam and obtain appropriate labs. And then lastly, engage the family in this new diagnosis and the treatment plan. Next slide, please.
Okay, so for our project, we specifically asked, is our clinic following these specific recommendations? So our study is a descriptive study, and we studied the well child visits of the pediatric population, specifically 2 to 17-year-olds. And this is spanning around 3.5 months. So from June 22nd of 2024 to end of September 2024. And we did study the well child visits at both our resident clinic at the Family Medicine Center, as well as the attending clinics and the attending clinics at the Loyola Family Medicine Center. And we did look at multiple variables, including their basic numbers like age, BMI percentile, whether or not they had a documented obesity diagnosis, if they had a documented exercise recommendations, if they had screening labs ordered, referrals, so anything like bariatric programs or nutritionists, if they had a follow-up, their blood pressure, of course, if they had, so all these are like documented evidence of these, so lifestyle discussion, as well as if they need an interpreter, insurance, and ethnicity. Going on to the next slide.
So we found that childhood obesity is very prevalent in our clinics. So we reviewed a total of 877 well child visit charts. 636 were charts from McNeil Family Medicine Center that included residents, and then 240 from Loyola Family Medicine that were multiple attending providers. So this bar chart here, you can see on the left side, McNeil had 25% of their children were obese. And then in the middle, you have Loyola, 30% of children had obesity. And then the national rate is 18.5. So you can see that both of our clinics that we studied, this is more than 1.5 times our national rate of pediatric obesity. So again, a really, really big issue. Next slide, please.
And just to show you some general information about the data we collected in the span of about 3.5 months, we looked at most of the well child visits took place in the month of August, and most were seen by the second-year residents. And that's likely because this was before school starts, and they were trying to get the school physicals done. Going on to the next slide.
All right. So we were looking at children with obesity, and we wanted to see if obesity was identified and labeled in the chart during each visit. So on the left side, we were looking at McNeil Family Medicine Center. So 55% of these obese children had the diagnoses in their chart for that visit, while only on the right side here, only 22% at Loyola had that diagnosis in their chart during the visit. So again, this is very, very important back to kind of like identifying the problem, because if we don't identify it, we're not able to recognize it, and then we're not able to address it, which is our goal. Trying to see, like, make sure these children are getting the care that they need. Next slide, please.
So we also looked at, did these children who got the diagnosis of obesity get any, or who had obesity, so even if they didn't get documented diagnosis of obesity, get any lab workups? And it showed that most of the children with obesity did not get any sort of lab follow-up. So 78% at McNeil and 82% at Loyola Family Center did not get any labs. Next slide, please.
All right. So we were also looking to see whether LFTs were ordered for these children with obesity. On the left side, you see only 19% of the children had this lab ordered. And then on the right side, you can see 23% of these children had the lab ordered. So again, this is a grade A recommendation and almost less than a quarter. Next slide, please.
Okay, so not only did we look at the labs, but we also looked at to see if these children with obesity had any sort of follow-up appointments to discuss this issue. And our study showed that most children with obesity actually did not have any follow-up to discuss their obesity. So many were actually lost to follow-up period, or had they just had another well child visit, which continued to not really address their obesity. So only 8% at McNeil Family Center and 1% at Loyola had any sort of follow-up regarding. Okay, next slide, please.
Okay. So we also looked at their blood pressure. So many children with obesity had elevated blood pressure. So on the left side at McNeil, 18% of them had an elevated blood pressure. And on the right side here, you see that only 8% at Loyola had an elevated blood pressure. So again, just kind of addressing and recognizing those comorbidities that we're trying to prevent the development of. Next slide.
And then of these children who had the high blood pressure, we looked to see if this blood pressure was addressed at all. So the answer was that around half or more did not have their high blood pressure addressed, or at least documented in their notes. So blood pressure is a comorbidity, and as you remember, it is a grade A recommendation to treat the obesity and comorbidities currently in pediatric populations. So 41% with elevated blood pressure had discussion, and 50% of Loyola had any sort of discussion about high blood pressure. So this is another area that could be improved in the future.
And then we also looked at whether referrals were being provided during these well child visits. On the left side, you see at McNeil, only 16% of the patients had a referral place. And then on the right side at Loyola, it was only 4%. So again, making sure that they're getting the appropriate referrals is very, very important. Next slide, please.
Okay, so in conclusion, our study showed that we can be more proactive or aggressive in diagnosing and following up on obesity and its comorbidities in these children, especially during well child visits. This can mean like labs or referral to nutritionists, or simply having multiple follow-up visits just to talk about their weight. And our research did open up many areas for further research. So one of which is how can we adjust the format of our well child visits to better identify and address these gaps. So how can we kind of make it almost automated that we can identify like children with elevated BMI, that we can have that diagnosis in their charts.
You have about a minute and a half remaining.
Okay. And the next slide, please. So these are some of the resources we used. So that concludes our presentation.
And with that, I will open it up to Drs. Manning and Garcia if they would like to unmute and ask questions, or they can put them into the chat. And thank you both for your presentation. I'm going to keep the slides up there just in case they need to refer to any of them when there are questions.
This is Dr. Manning. Thank you both. I thought it was a good presentation with a good set out. What made you curious to take this project on? Because your results are quite concerning. Was there something that happened that triggered you all to look at this particular question in your settings?
I think the biggest thing we talked about was the amount of children with obesity that we see during our well child visits, but we don't really seem to have any sort of structure to address that systematically. So we wanted to kind of get the baseline data to where we're at, so in order to improve.
That's great. And what is your total N? You may have shown that, but I missed it. I saw most of the percentage graphs, but not how many were at each site.
I think our total was 700 and something. Oh yeah, here.
Okay.
Oh, 877. We reviewed them and then we kind of distinguished whether they met the criteria for obesity or not. And then it was kind of like 2/3 from the McNeil Clinic and then 1/3 from the Loyola Clinic.
And why do you think your excellent group and your excellent Loyola group have high quality standards and have a great reputation? Was there any thoughts about why this might be true? Do you think it was the summertime as you're looking at those 3 months, or was there anything else that you thought might have interfered with the BMIs being attended to by the physicians?
One thing we did think about was a lot of well child visits tend to kind of follow our specific, I guess, sort of template, and there isn't really a section that addresses whether or not children has obesity or like high blood pressure. It just has a very generalized, maybe like their diet or things like that. So I think so that's actually an idea we had to change up the format or template of our well child visits. So if it kind of prompts us to almost force us to think about, like, does this child have elevated BMI? Like, does this child have comorbidities? Like, we don't have to talk about it then and there, but at least schedule a follow-up.
That does kind of lead into Dr. Garcia's question, which she put in the chart about your data. She says, given the population at McNeil, other than improving the flow of the visit, as you kind of mentioned, are there any other interventions that you're considering?
Yeah, so like Dr. Kim mentioned, like changing that template to kind of not be so generic. And also we wanted to kind of more educate the residents more on this topic because we don't get a lot of education specifically on pediatric obesity. And there's just so many guidelines with what lab work to order, at what age do you get lab work and all that stuff. So we kind of learned all about that with this project as well. So kind of incorporating this knowledge during our like, protected learning time is something we also wanted to do. And then the next question from Dr. Garcia, do you feel that this is a lack of time, lack of education, etc.? I think definitely a lack of time. Because again, like a well child visit, we want to make sure that they're growing appropriately, they're doing well in school, they're getting their vaccines, maybe they have some other chief complaints and stuff like that. And then sometimes we may not even have time to even touch the topic of their elevated BMI. So that's definitely something that kind of contributes to it. And lack of education, I think, as well, because I've had patients where very, very small amount of patients that tell me that their child is very skinny and their BMI is normal, like normal. But because obesity is so prevalent, that's like the norm now. So I guess just educating parents and just educating patients in general that, hey, this is actually not normal. And what people consider too skinny in children is actually normal. So just kind of like educating patients, educating residents so that they have the knowledge to kind of, educate their patients as well.
All right. Well, thank you both very much.
Just one more comment. I agree with you that if you're looking at the peer group are all have very high BMIs, that the parents and the families do not feel that you're addressing something that's necessary. So it really takes that multi-intervention. And one last thought was you said LFTs, but I think they're only advised at age 10 on. So as you look at what labs are done, you might want to be more parsimonious about what age those are required. But great job. I hope you do an intervention and then come back with the follow-up.
Yes, someone else will hopefully take over that part of the project.
Great. Looks like your efforts would be supported. So thank you both so much. Now we are up to 5:40, which is our final presentation of the day. I know Dr. Abataleb is on. Can we make sure we can hear you and you can pull up your slides?
Yes, hi.
Okay, well,
I can. How are you doing?
Good.
I can share my screen.
Okay, while you're doing that, I'm going to go ahead and formally introduce Dr. Soha Abataleb. I hope I said that correct.
Yes, correct.
Okay, she's with the University of Chicago Advent Health Hinsdale Family Medicine Residency Program with a completed project. And the final reviewers of the day, thank you, Dr. Manning, for all your help, is we'll have Dr. Rabinovich and Dr. Garcia be our reviewers who will score your presentation and present questions after you finish. You'll have 15 minutes to deliver your slides. You can go less than 15 minutes. I'll give you a 2-minute warning if you get to that point. After you finish your slides, then Drs. Rabinovich and Garcia will either unmute and ask a question, or they'll put it in the chat and I'll read it aloud, and we'll look forward to your presentation. Do you have any questions?
No, thank you so much.
Okay,
Thank you very
then
much for your help.
my job is to wish you good luck, and the clock will begin when you start your presentation. Thanks for being here.
Perfect. Hello, everyone. This is Dr. Abataleb. I'm a PGY3 at Hinsdale, U Chicago Advent Health Hospital, and today I'm going to present my research project about implementation of Edinburgh postpartum depression scale to screen for postpartum depression in Hinsdale Family Medicine Clinic. Then this is the disclosure. Postpartum depression is a common but often underdiagnosed condition affecting new mothers. The importance of the screening is to early detect the postpartum depression after delivery. Early detection allows timely intervention and improve maternal and infant outcome. Edinburgh postpartum depression scale, I use this scale specifically because postpartum depression in general can significantly affect both mothers and infant, including bonding, breastfeeding, child development, and maternal safety. Many patients may not voluntarily report symptoms, so screening help identify at-risk mother early and allow timely intervention. This scale consists of 10-item self-reported questionnaire designed to identify symptoms of postpartum depression, and it's widely validated and used globally. This is how the screen look like, and it is composed of 10 questions, each scored from 0 to 3 with maximum score of 30. Higher scores suggest a greater likelihood of postpartum depression. Many institutions use a cutoff around 10 to 13, depending on sensitivity goals and patient population. Then this is the next page, also showing the questions that the mom have to answer in postpartum, 2 weeks, 6 weeks, and also all well child until 1 year. Then this is how the Edinburgh scoring system works. From 0 to 9 indicate normal mood or minimal symptoms of depression. From 10 to 12 suggest mild to moderate depression. And at this point, further evaluation is needed, like repeating the test in 1 to 2 weeks. From 13 to 30, that's indicate moderate to severe depression, and immediate follow-up and treatment are recommended. What is the next step after positive screening? First, refer the patient to mental health professionals such as therapist, counselor, or psychiatrist. Treatment option like psychotherapy, cognitive behavioral therapy, support group, or medication like SSRIs. Also support system, encourage support system from husband, friends, family, community group to help patient cope with postpartum depression. Review of literature. This scale developed in Edinburgh University by Cox and Holden in 1987. Developed and validated the scale, and it's recommended as a reliable screening tool. Also, ACOG, the American College of Obstetricians and Gynecologists, recommended routine screening for depression during postpartum visits. The study show implementation of educational programs to providers and residents to improve screening rates, regular use of Edinburgh scale to enhance early detection and treatment adherence. The objective include increasing awareness of postpartum depression, increase administration of the scale in Hinsdale Family Medicine Clinic in postpartum visit and newborn visit, and also to evaluate the effectiveness of an educational lecture on improving the implementation of the scale in postpartum and newborn well-child visit at Hinsdale Clinic. The method, the study design is a quality improvement project, and it was implemented in Hinsdale Clinic. The data collection, I reviewed 758 chart pre-lecture and 743 chart post-lecture, included both postpartum and newborn well-child visits. We use like an educational lecture on the importance of using the Edinburgh postpartum depression screen. And we measure the outcome by the percentage of chart documenting completed Edinburgh scale before and after the lecture. And the result as a cumulative for both like postpartum and neonatal. The total of the chart is 758. The Edinburgh applied was on 310 chart, which is represent 41%. Then after the lecture, there was increase in the percentage to 66 percentile, which is 490 chart. The Edinburgh scale was applied. Key finding that the overall Edinburgh scale implementation increased by 25% after the educational intervention. Then the result by visit type, the postpartum visit, pre-lecture was 43 percentile of the chart applied the scale. After the lecture, it increased to 68 percentile. In newborn visits, there was like a 38 percentile pre-lecture, increased to 62 percentile post-lecture. So both visit type showed significant improvement of post-lecture. Education positively influenced provider to adhere to Edinburgh postpartum skill screening. And these are the graphs to show like pre versus post lecture, the cumulative percent, 41 against 66 post lecture percentile. Then this specifically, this is the chart specific for the postpartum visits, which is 43 pre-lecture and 68 post-lecture. Then this is the graph for the newborn visit. It's 38 percentile pre-lecture and increased to 62 percentile post-lecture. The conclusion, the educational cessation effectively improved awareness of screening compliance. Higher screening rate allowed for earlier intervention and better maternal health outcome. Reinforcement through ongoing education and chart reminder may sustain improvement. Implementation of an educational intervention significantly improved the screening rate. Edinburgh screening rate is an effective, easy-to-use tool for early identification of postpartum depression. Continued provider education and integration into clinic workflow are essential for long-term success. And that's all about it. And open for any questions.
Great, thank you so much, Dr. Batsaleb. Dr. Rabinovich or Dr. Garcia. Dr. Rabinovich has already put his question in the chat. First, thanking you for your presentation. Why do you think the rates were so low before the lecture?
Because like the main reason that we discover that we have always like a built-in dot phrase for the well child from categorize for each age, like from 0, 2 weeks, 1 month, 2 months, and so on. And in the built-in, there was like only focusing on the to ask the mom the BHQ9 to assess for postpartum depression screen, and there was no Edinburgh postpartum depression screen. So what we did, that we did an educational lecture about that. Then we applied the Edinburgh postpartum depression screen on the dot phrases, so the resident can remember, and also the provider can remember and can apply it on each visit.
And he added a follow-up question asking, how did you determine that a lecture was the best intervention instead of having MAs pass off the screen or a different intervention?
Yes, also this what was not like taking care before. That was like we were given the lecture, we were like, you know, advised to do and apply the Edinburgh scale, but none of this intervention were made. Even like one of the intervention that I while data collecting pre the lecture post lecture, I told the MA to give like the scale. I printed the scale and put it on the nurse station and asked the MA to help me and distribute the scales to each like postpartum visit, female or in the well child from 0 to 6 months. And they did, and that caused a tremendous improvement of the application of the scales.
Great, thank you. I'll hold out for a minute and see if Dr. Garcia has any questions. Either unmute or you can put it in the chat if you would like. And while we're waiting for that, I may even throw a question out for you. I noticed that the numbers pre and post lecture for the actual newborn visits was lower, almost proportionally. Do you have any knowledge if that was ever because the adult accompanying the newborn wasn't always the mother?
No, I'm not sure. Like sometimes the mom comes alone, sometimes her partner come alone, but I make sure that the partner does not interfere with the mom answers. So she always answer independently while the partner is holding the baby, feeding the baby, or you know, standing away from the mom while she is answering to you know, to eliminate observer bias.
Okay, and Dr. Garcia has added a question asking, did you look for any change in documentation of the results? If the MA was crucial in getting the screening done, did the provider actually document a review and plan?
For all like the chart I reviewed, there was no like positive screen. Like all of them scored between 0 to 9, which is minimal or like normal. So we didn't need like to intervene more or to like, you know, send them to you know, therapist or consult our behavioral health to come and talk to them or counsel them to see a therapist or a psychiatrist. Because all of the chart show minimal like score, which is between 0 to 9.
Thank you. I'll hold out to see if there's one more question. Thank you, Dr. Rabinovich. Why do you think the post-intervention didn't get to 100%? Why 66%?
Like, yeah, that's a very good question. I think it's because like not all of the resident and the provider like and also the MA, they helped a lot, but they weren't like compliant 100%. So sometimes post lecture, I find some of the chart was missing the Edinburgh postpartum screening scale. Only BHQ9 was applied, but the Edinburgh was not there. Yeah.
Okay. All right. I think that may be it for your questions. So thank you so much. And with that, that concludes our final presentation of the 14th Annual Summit. I want to thank all of our presenters in this block, as well as Drs. Rabinovich, Manning, and Garcia for their time this evening. Just a reminder to those reviewers, please submit your scores through the online survey by the end of today. Then I will be taking those scores and comments from every presentation, compiling them tomorrow with the goal of sharing the scores and comments to each lead presenter by end of day tomorrow. And then the recording will be shared as well. So thank you so much to everyone for your time. And we'll look forward to posting individual scores to you individually and sharing the names of the top scoring presentation in each category by the end of the week. And with that, thank you so much for your time, and we'll see you guys again next year.